including obstetric critical care and extracorporeal therapy. Our next chairperson is Dr. Snehal Sanghvi, sir. He's the mentor of the Internal Medicine Department of Sir H.N. Reliance Foundation Hospital. He has a rich experience of around 39 years. He is associated with many other hospitals in Mumbai. He has a vast teaching experience also of more than 39 years. He has taught at medical colleges of Grand Medical College and GS Medical College. He's been a postgraduate teacher for MD Internal Medicine also. He has a diploma in diabetes mellitus at Cefi Hospital, and he's a recognized teacher by the National Board of Examinations for DNB at Cefi Hospital. So we'll welcome both of them to start the session.
Good evening, everybody. Dr. Divya, thank you for such a nice introduction. The first speaker today is Dr. Joy Desai. Yesterday, we had a brain-stimulating lectures and topics by various speakers on intracerebral hemorrhage and other interesting brainstorming topics. So today, we are going to have the first speaker of the third session is Dr. Joy Desai, who is a consultant neurologist, Sir H.N. Reliance and Justlock Hospital. He is a DNB teacher at Justlock Hospital since more than 15 years. And he has a special interest in epilepsy, neurodegenerative disorders, and sleep disorders. Besides this, with such a vast clinical experience, teaching experience, he has been always a smile on his face. And when not a neurologist, he is a tracker, photographer, and an artist. He is going to talk on the topic today of the risk factors mitigations in the stroke. As we all know, the stroke is a very important cause of mortality and morbidity all over the world. So let's have what Dr. Joy Desai is talking about, the dream or in the pipeline or fact. Here I present Dr. Joy Desai.
Thank you, chairpersons, and thank you, organizers and Dr. A.B. Shah for asking me to participate here today. My brief here is to speak about risk mitigation in stroke. As you must have understood from my CV, I'm normally not a stroke specialist, but my interest in risk mitigation comes from my interest in lifestyle. So what is it? Is it a reality or is it a pipe dream? We must understand that stroke is equal to brain loss, and strokes can be thrombotic, they can be embolic, or they can be hemorrhagic. We know that arterial thrombotic strokes can be large vessel, medium vessel, or lacunar. We also know that venous strokes can sometimes be an alternative subset of thrombotic strokes in the brain. We know that hemorrhagic strokes can be devastating when parenchymal or subarachnoid in their location, with differing risk profiles and outcomes based on the severity and who the patient who suffered the stroke is. So can stroke be really prevented? What do we know about that? Well, so prevention of stroke can be conceptualized into two categories, either primary prevention or secondary prevention of stroke after the actual occurrence of an event that could be designated as a stroke. We know that risk factors like age, gender, and family history is something that is not modifiable. But on the other side of the coin, our experiential wisdom tells us that there are some modifiable risk factors that could be mitigated when one considers an individual's risk for stroke. So what are those? We should not start or quit smoking. Never start smoking or perhaps quit smoking. Maintain a healthy weight. Eat more fruits and vegetables. Consume alcohol moderately, if at all. So if at all consume, then consume moderately. And we'll talk about that. And obviously, the most important thing being physically active. So there is a lot of evidence-based literature on nuances of these factors that are relevant for stroke prevention. So what about secondary stroke prevention? We know that it's dependent on the identification of the type of stroke, the location of the cerebrovascular event, the mechanism of stroke. Was it atherothrombotic or was it cardioembolic? We are aware that atherothrombotic events can be analyzed, as I said earlier, or it's large vessel, medium vessel, lacunar. And cardioembolic can be arrhythmogenetic, that means they arise from an arrhythmia, could be paradoxic, PFO related rarely, can be dyskinetogenetic, that means that they arise from a dyskinetic segment in the myocardium, or could be infectious or merantic endocarditic. That means an individual has infectious or merantic endocarditis, and there's an embolism from the inflamed cusps of any of the valves in the ventricular, in the atrioventricular junction. Thrombotic events can be subcategorized as either primarily or secondarily prothrombotic. So there could be a prothrombotic disorder. They could be commonly or uncommonly migraine related, and very rarely could be carcinoinvasive in someone with a large burden of tumors. And lastly, hemorrhagic strokes are related to inherent or acquired congenital vulnerabilities, berryaneurysms as we know them, or arteriovenous malformations, and sometimes to acquired change with age related to hypertension and amyloid angiopathy. So the American Stroke Association has this questionnaire which is put up in every stroke clinic in the United States. The question is to ask what could be modified. Has the patient had a stroke? Well, yes. If the answer to that is yes, the risk of a recurrent stroke is 6% at 1 year, 16% at 5 years, and 25% at 10 years. Has the patient experienced a TIA? Approximately 12% of all strokes are preceded by a TIA. So that could be relevant. What's the underlying cause of the stroke? If the etiology of the stroke has not been determined, consider collaborating with other individuals to evaluate the cause. If this was an ischemic stroke, then the guideline is that aspirin, variable dose from 50 to 325 per day, in combination sometimes with extended release dipyridamole, could be indicated in a person after a TIA or an earlier ischemic stroke for prevention. What about hypertension? Treatment of hypertension is possibly the most important intervention for secondary stroke prevention. And the target, we all know, is that blood pressure should be maintained below 130 systolic and below 80 millimeters of mercury diastolic. If the patient has diabetes, we need to control that. If the patient's cholesterol is elevated and of the cholesterol elements, we know that LDL cholesterol is something that we are interested in, and patients who have had a stroke and are at risk further need to keep their LDLs below 70. Is the patient physically inactive? There is a lot of data to show that physical activity of at least 3 to 4 sessions, about 40 minutes of moderate to vigorous intensity aerobic physical exercise, is an important regular intervention for stroke prevention. If the patient's a smoker, we need to ask them to cut smoking. Dietary changes, there are epidemiological studies that reveal that fruits, whole grains, low fat dairy products, fish, legumes, nuts, limits sodium, limits sugar, and limits red meats. And that kind of a Mediterranean kind of diet um, is associated with a lower stroke risk. What about alcohol? And this is a question that almost every patient asks every neurologist. And we have data to show that very light amounts of moderate alcohol consumption, maybe a drink a day for either men or women, might be reasonable. But if possible, any larger doses of alcohol consumption are associated with a higher stroke risk. Does the patient have sleep apnea? This is an emerging science, and we will talk about that in further slides. This is a meta-analysis from 2003 that was published in Stroke, and out of various studies that were done, there is large body of evidence that moderate and high level of physical activity is associated with a reduced total risk of stroke, both hemorrhagic and ischemic. And the relevance of this comes from various physiological changes that are ameliorative when one is active versus when one is sedentary. And the last 13th question that is asked in the AHA leaflet is that has the patient been diagnosed with atrial fibrillation? We know that atrial fibrillation is a powerful risk factor for ischemic stroke from cardioembolism, and that needs therapy in different ways. So how does one know that an individual is at risk from stroke from atrial fibrillation? So there is a score that's been devised, and this has been validated. It's called the CHA2 DS2 vascular score. There's congestive heart failure, you score 1. Hypertension, you score 1. Age 75 and older, score 2. Diabetes, score 1. If one has had a stroke or an ischemic event, score 2. If there is vascular peripheral disease, score +1. If age is between 65 and 70, score 1 instead of 2. And if one is a female, then you got to score 1. On top of that, what is the risk association? This is the risk association. What it shows is that if your score on this scoring system increases, say, from 1 to 9, as shown in this bar chart from left to right, then one can see that the percentage per year of thromboembolism from atrial fibrillation graphically increases from what you can see as 2% in when you have a score of 1 to virtually about 15% when you have a score of 9. So we have objective parameters which can tell us who is at risk, and if these risk factors are present, one can mitigate them. So what do? We anticoagulate them. The age-old vitamin K antagonist warfarin has been with us for many years, and we know how to use it. We target an INR between 2 and 3, and we know its pharmacology. Now there are new contenders to this august throne. We've got rivaroxaban, we've got dabigatran, you've got apixaban, you've got endoxaban. And I'm pretty sure that in a couple of years, we'll probably have some more contenders to the throne. At this moment, um, head-to-head comparisons are difficult to make, and one has to make an individual choice in choosing a anticoagulant. And we know that at least rivaroxaban and dabigatran both have been approved for cardioembolic strokes from atrial fibrillation, and one could deploy them in a vulnerable patient. What about primary prevention and hypertension? That is completely a no-brainer. There are numerous trials, but if one looks at 14 randomized controlled trials, we have data now from over 37,000 patients. And this data shows us that a reduction in diastolic blood pressure just of 5 millimeters of mercury, primarily with a diuretic or a beta blocker as a simple antihypertensive, can lead to a 42% reduction in stroke risk. And this is a very, very significant finding. And if we know this, we clearly know that if you're going to mitigate stroke risk, we've got to make sure that our patients are not hypertensive. There are two large studies. These are two studies that are quotable and they are worth knowing. There is a study called Progress, Perindopril Protection Against Recurrent Stroke, where they randomized 6,105 patients with a history of stroke or a TIA to an AC inhibitor, an angiotensin converting enzyme inhibitor, perindopril, with or without a diuretic indapamide. And on therapy, there was a 28% relative risk reduction for recurrent stroke. In a similar study called PATS, the post-stroke antihypertensive treatment study, 5,665 patients were given indapamide as a diuretic versus placebo, and there was a 29% decrease in recurrent stroke. So clearly, hypertension is something that we do not want to ignore. Hypertension is something that we want to seriously control. Now, what about a patient who has had what clearly to a seasoned physician or neurologist has had a transient ischemic attack? Now, when this individual comes to the clinic, how do we know that such an individual is at risk for a future stroke? So we have a scoring for that. That score is called the ABCD score. And I put it up here on the slide. If the person's of aged 60 or above, then you score +1. If blood pressure is more than 140/90, score +1. If there was unilateral weakness, score +2. If there was speech disturbance without weakness, score +1. If the duration was less than 10 minutes, then you scored 0. 10 to 59 minutes, +1. More than 60 minutes, you score +2. And add to that presence or absence of diabetes, you can score +1. So if you have this ABCD score, then this risk becomes pretty apparent. How apparent is it? This is the data that we have from studies. If the ABCD score is 0 to 3, it's a low risk category. 2-day stroke risk is 1%, 7-day stroke risk is 1.2, and the 90-day stroke risk is 3.1. Whereas on the other side of the coin, if you had a much higher score, say 6 to 7, then you're at a high risk with a 2-day stroke risk of 8%, 7-day 11.7, and 90-day at 17.8. So clearly, we have features that we can identify. If we know this, if we have an algorithm, if you have a little sticky on your table, you can use this to assess stroke risk. And what do we treat them with? Well, it's fashionable to use dual antiplatelet therapy, but we have got two studies that give us a word of caution. There's a study called MATCH, Management of Atherothrombosis with Clopidogrel in high-risk patients, and there's a study called SP3. Both of them demonstrate that adding aspirin and clopidogrel to a high-risk patient with a recent ischemic stroke or TIA does not change the difference in major stroke events, but it increases the risk of life-threatening or major bleeding. So if one is giving dual antiplatelets, then maybe for 21 days, not longer. And that's the sobering bit of information we have. And SP3, again, had similar results. So what we know now is that if someone is at risk of stroke from these factors that are identifiable at the bedside, what could one do? One could give them aspirin. There are different studies for variable dosing, but anything between 75 and 150 is appropriate. An alternative could be clopidogrel. It is not recommended to combine aspirin and clopidogrel by and large. There are some studies, two studies actually, that show that extended release dipyridamole 200 milligrams plus aspirin 25 milligrams 2 times in a day could be equally effective in mitigating stroke risk. Now, what about ticagrelor? So we know that ticagrelor is in the market. It's an alternative. Why should it be a cause for attention for us as Asians? We know that for the primary antiplatelet clopidogrel in amongst the Asian population, there's a perception that between 40 and 60% could actually be resistant to the agent. So we were looking for an alternative, and we have got ticagrelor. There's an ongoing study called TALIES. It's acute stroke or transient ischemic attack treated with ticagrelor and aspirin. The study is underway, and maybe in a few years we'll come to know whether the addition of ticagrelor to aspirin is going to change our stroke risk in our vulnerable patients. And lastly, the last study that I think is an eye opener is the study called COMPASS. This COMPASS study enrolled 27,395 patients with stable atherosclerotic vascular disease and randomly assigned patients to rivaroxaban 2.5 milligrams plus aspirin 100 milligrams daily, or the second arm had rivaroxaban 5 milligrams twice a day, and the third arm had aspirin 100 milligrams a day. And the study was stopped early because of efficacy, which demonstrated that rivaroxaban 2.5 twice daily plus aspirin had a much better outcome in prevention of cardiovascular death, in prevention of stroke, and prevention of myocardial infarct. For those who are interested, this study is freely available for review. You could download the study. If you key in COMPASS on Google, you'll get it. And this is the bar chart showing the difference in stroke risk. What's shown in the middle in the lighter blue is the reduction in stroke risk at 12 months, 24 months, and 30 months. So clearly, COMPASS trial does seem to show that there might be a new contender to the throne for therapies for stroke reduction in vulnerable populations. So in summary, what we know is that anticoagulation, either with warfarin or a direct agent, is useful in cardioembolic stroke. Aspirin, triple antiplatelet therapy with aspirin, clopidogrel, and dipyridamole is not recommended. Cilostazol and ticagrelor are at this juncture considered investigational. There is some data, but their precise role is unknown. So I think we'll know maybe a few years down the line. And statins for dyslipidemia, yes, we know, we use that. Ezetimibe for those where there may be statin intolerance or a side effect. And there are some new agents. There is a proprotein convertase subtilisin or kexin type inhibitor, which is to be given subcutaneously, but it's horrendously expensive. And perhaps these agents might pave the way for future therapies in time to come. There's a little word of caution for patients who have what is called lacunar strokes. And in this very lovely study published by Edip Gurol, there is a review of how we know so little about the pathophysiology of small vessel disease in the brain. And the recommendation is that dual antiplatelet therapy are singularly risky in such lacunar infarcts and small vessel disease. Why should that be so? Well, there is experiential data to show that they are at high risk of secondary hemorrhage. And these are images which show that what can happen if you give dual antiplatelet therapy to a person with small vessel disease and lacunar syndromes. And this diagrammatic representation tells us that the pathophysiology of this lacunar stroke disorder is fairly different from the routine pathophysiology of strokes. And this has been reviewed extensively. There's a study by Robert Regenhardt, which is shown on the right. There's a study by Louis Kaplan. Very lovely review. It's worth reading that. And in a sense, what they are telling us is that lacunar strokes seem to have a different pathology. What initiates it? Hypertension, diabetes, vascular amyloid, oxidative stress, and there is growing information about sleep apnea. It results in vessel dysfunction. So what happens is that there is vasoconstriction, auto and procoagulatory change, inflammation, and proliferation. So there is fibrinoid deposition in the vessel wall. It gets disorganized and it leads to ischemia, infarction, and attempted repair. there is a high risk of thrombosis, of hemorrhage in such patients when they are either anticoagulated, thrombolized, or given dual antiplatelet therapy. And the new interest is on finding molecules that can antagonize matrix metalloproteins. We know that matrix metalloproteins, especially MMP9, is responsible for this gap junction regulation at the astrocytic foot process and the blood vessel. And this results in the lacunar pathophysiology. If we find an agent that works here, perhaps there will be a therapy which is different from what we know. What about sleep apnea? Way back in 2005, this study in New England Journal of Medicine for the first time correlated the risk of strokes with the presence of obstructive sleep apnea. And subsequent to that, there have been numerous studies. I've shown you some of them, each one asking the emergent question that are we neglecting a modifiable stroke risk factor when we ignore sleep apnea in our patients who do not necessarily come to the clinic with an outstanding story of OSA. And what we know now is that in a small study, these are 43 patients, this is again published in Stroke. If one looks at patients who have stroke and have sleep apnea, all of them have elevated levels of tumor necrosis factor. They have elevated levels of interleukin 6 and plasminogen activator inhibitor 1. So they have a chronic pro-inflammatory state, and we know that that makes them stroke vulnerable. And now we have a body of literature, and this is all synopsized from the American Stroke Association. If one has an apnea-hypopnea index of more than 20, and even if one adjusts for BMI and adjusts for other risk factors like diabetes, hypertension, and the presence of an enlarged LA or atrial fibrillation, it still confers a 3.5 to 4 times higher risk of stroke. So sleep apnea is something that we cannot ignore. We need to identify. We know that these are the risk factors for sleep apnea. And perhaps in future, this is going to be a routine investigation in patients with stroke. And many sleep specialists and many stroke specialists look at sleep apnea. So what we clearly know is that there is a whole spectrum of modifiable risk factors: hypertension, diabetes, dyslipidemia, smoking, sedentariness, sleep apnea, heavy alcohol intake, and diet. All of that could actually be changed. What about hemorrhagic risks from malformations? And these are two illustrations. We all know about congenital perianeurysms, and we know about arteriovenous malformations, and we know that they are congenital. And the suspicion is that we have genes which make these vessels vulnerable to an anatomical abnormality that could result in cerebral hemorrhage, either in the parenchyma of the brain or in the subarachnoid space. So for aneurysmal risk rupture, we have a risk score. That risk score is called phases, and this is phases. So if it depends on what is the population, if you are a Japanese, then there are 3 points given. If you're Finnish, they have a high risk of rupture. They're given 6 points. If you're hypertensive, you're given 1 point. If you're 70 years or older, it's 1 point. The size of the aneurysm matters. 7 to 9.9 millimeters, 3 points. 10 to 19 millimeters, 6 points. And greater than 20 millimeters, 10 points. Has there been a earlier subarachnoid hemorrhage? 1 point. An internal carotid artery location versus middle cerebral artery versus the two communicating arteries, anterior and posterior, and the posterior circulation, they are at higher risk, so they're given 4 points. So based on the phases score, one can actually arrive at a percentage hazard ratio. So if your score is 4, for example, your percentage hazard ratio for a rupture is 0.9. If your score is 10, this jumps to 5.3. So again, here we have factors which can be identified, which can be made objective, and which can be looked at the bedside and can be associated with imaging parameters. What about arteriovenous malformations? We know that age, Hispanic ethnicity, deep brain location, and exclusive deep venous drainage confer additional risks for AV malformations to actually bleed other than previous hemorrhage from the AVM. There is a very illustrative study. This study is called Aruba, the medical management versus interventional therapy versus medical management alone for unruptured AVMs. And this Aruba was started in 2014. And in 2020, just a few months ago, JP Moore from Boston has published this in Lancet Neurology. And the study has very clear, definitive outcome findings that if someone has an unruptured arteriovenous malformation, then by and large, they are best left alone. Once there is a rupture, then one can assess the bleeding risk and then take a choice of getting it treated. So at this juncture in 2021, in February, it appears that patients with AVM have a higher rate of neurological morbidity and mortality after preventive interventional therapy. So perhaps they are not to be treated unless and until they have actually bled. And once bleeding has occurred, then one may use the scoring system to arrive at a recurrent hemorrhage risk and take appropriate activity. Having said that, it's left to seasoned neurologists to decide to choose depending on how severe are, say, secondary epileptic seizures from calcification of the AVMs and so on. And that could be an exception to the findings of the study. So really speaking, we've got a lot of scientific data that can demonstrate mitigation um, factors that are relevant to the risk of stroke. So the take-home messages for all of us are that risk mitigation is not a pipe dream. It's a clear reality that can be achieved at a community level. Knowledge of stroke subtypes and its mechanisms leading to their precipitation has increased in leaps and bounds, and every day we are learning something new. Clinical trials have shed some light on preventive measures, some which are sobering, some which are unequivocal in a positive outcome for risk mitigation. And we have quoted some of them in this presentation. Lifestyle management is the key, and that is what we need to do at a community level. This is limited by very dismal public awareness on lifestyle related risk factors for stroke, and somewhere we need to promote advocacy for this to change. And risk mitigation advocacy at a community level has to become a priority if we are going to change how many stroke patients we look after in tertiary hospitals and in community settings. And lastly, I have this last slide for an illustration. This is a patient whom I saw in this hospital just about a week ago, or maybe about a month ago. And this is a 42-year-old housewife with a minimal education, mother of two children, who was aligned for a religious pilgrimage to her hometown. Her menstrual cycle was due on the day of departure for the pilgrimage, and her peers believed that it was inauspicious for a menstruating woman to enter the holy precincts of their community temple. So, what did she do? She sought advice from the neighboring chemist. And the neighboring chemist promptly handed her a strip of OC pills and said, "Take these pills and you can stop your cycle from actually emanating." She mistakenly consumed 8 of these in the belief that their anticipated benefits would be faster. And lo and behold, she developed a very large and catastrophic cerebral venous sinus thrombosis, huge infarct, coning, and she came in here in an imminent coning state. We had to do an emergency temporal lobectomy, a craniectomy to save her life. And she did survive. She's now recovering. It's been about a month and a half. She's back to walking. She still has a flail hand and has a dense hemianopia. And this case illustrates why advocacy and knowledge has to be disseminated at a community level for us to be successful in our attempts at preventing strokes from occurring. Thank you for your attention. And that's my last slide.
Okay. Joy, a very good lucid lecture where you have covered lots of aspects on primary and mainly secondary prevention, and the sleep apnea particularly as a risk factor which is coming in. And I really thank you that it is a very good, excellent, lucid, and covered lot of aspects about this mitigation factors. And as your topic said, yes, it's a reality and it's not a dream. Thank you
So much. Thank you.
We have a second speaker, right?
Yes,
Doctor?
sir, I'm here.
Yeah, Dr. Dasna Rathod. who is a consultant in the critical care medicine at HN Reliance Foundation Hospital and Research Center. After completion of MBBS, she has done the residency in internal medicine at Grant Medical College and JJ Group of Hospitals. So she had the MD medicine background with intensive care, and she has an extensive experiences in the medical emergencies, intensive care, and surgical intensive care units. She has worked at various reputed hospitals like Asian Heart Institute, SL Raheja Hospital, Bhakti Vedanta Hospital. At present, she's working in Reliance Hospital, and she has an interest and specialization in invasive and non-invasive mechanical ventilation, intra-aortic balloon therapy, and hemodynamic monitoring. She has an expertise in operating and providing the protocolized care in ICU. She is going to talk about the pneumonias in the stroke. As we all know, that stroke patients are lying in the bed for a long time, maybe on the ventilator, altered sensorium, and none other than Darshana can tell us how to deal with these problems of pneumonia or infections in cases of the stroke. Yes, Dr. Darshana, please.
Good evening, sir. Uh, Good evening, everyone. Thank you, sir, for the introduction, and thank you, Dr. Arun Shah, for giving me the opportunity to present on this topic. And this is a day-to-day in our day-to-day practice, we see this quite extensively. So to start with, just to let you know what is stroke-associated pneumonia. Stroke-associated pneumonia is the recommended terminology for the spectrum of lower respiratory tract infections within the first 7 days after a stroke onset. And this is from Stroke, which was the Journal of the Stroke AHA, which has said in 2015. Why are we discussing about stroke-associated pneumonia? So stroke-associated pneumonia, overall, if you see the diagnosis in clinical practice is very challenging. Most of the stroke patients have some kind of infections, like as we see with the pneumonia, there is high possibility of a urinary tract infection also in this patient. And the source of fever and leukocytosis is often unclear in these patients. The appearance of the abnormalities on the chest X-ray are often delayed, difficult to differentiate between atelectasis, volume overload, and infiltrates of the in the X-ray. Then also all this leads to a pragmatic approach of management wherein we start the broad spectrum antibiotics even before the source of infection is clear. Again, this leads to an expensive cost because it also increases the length of the stay as well as the cost of the antibiotics, and it causes an adverse impact on the outcome by increasing the mortality. Incidence of stroke associated pneumonia, it is a high risk, high cost, high volume. Mortality from stroke, as we know, is the third leading cause of death, and chest infection may affect up to as many as one third of the stroke patients. Now, amongst this, pneumonia causes the highest attributable mortality of all medical complications following stroke. Respiratory failure from stroke again leads to intubation in up to 6% of patients suffering from an ischemic stroke, and 30% of patients with an hemorrhagic stroke. And the mortality rate from ventilator associated pneumonia, as we know, is estimated to up to about 20% to 30%. Post-stroke infection, a systematic review and meta-analysis in BMC neurology showed that in all the studies in approximately of 137,817 patients, out of all the patients in all the studies, they noted that almost infections were seen in almost 30%, and out of this 10% was pneumonia, 10% was UTI. And in ICU studies, out of the 45% of infections, 28% were pneumonias. So it concludes that infection is complicating the acute stroke in 30% of the patients, and rate of pneumonia and UTI is high, and pneumonia is associated with death. How do we diagnose stroke associated pneumonia? So first and foremost, we go through with the CDC criteria, wherein the patient has to have at least one of the following: fever of more than 38 degrees with no other recognized cause, leukopenia or leukocytosis. For adults of more than or equal to 70-year-old, altered mental state
status with no other recognized cause, and at least two of the following, that is new onset of purulent sputum or change in character of the sputum over a 24-hour period, or increased respiratory secretions or increased suctioning requirements. Second, new onset or worsening cough or dyspnea or tachypnea with a respiratory rate of more than 25 per minute, rales, crackles, or bronchial breath sounds, worsening gas exchange, that is causing example is O2 desaturation, a PO2 FiO2 ratio of less than or equal to 240, increasing oxygen requirements, and more than or equal to 2 serial chest radiographs with at least one of the following, and that is new or progressive and persistent infiltrate, consolidation, or cavitation. So with this criteria, probable stroke associated pneumonia is the CDC criteria are met, but typical chest x-ray changes are absent even after a repeat or a serial chest x-ray, and definite SAP is CDC criteria are met, including typical chest X-ray changes. There is limited evidence for diagnostic role with the consideration of WBC or C reactive protein in SAP. Pathophysiology of SAP, if you see with the acute ischemic stroke, there is an activation of the paraventricular nucleus of solitary tract, and locus coeruleus activation, causing activation of the hypothalamic pituitary adrenal axis, parasympathetic nervous system, and the sympathetic nervous system. This all lead to increased lymphocyte apoptosis, alteration in the inflammatory mediators, suppression of peripheral cytokine release, and inhibition of Th1 and alteration of Th1 and Th2 ratios. And this all lead to immunological alteration that is known as stroke-induced immunodepression. Again, the other two factors which have to be considered are impaired swallowing mechanism because of this, because of the abnormal dopamine transmission and low substance P, and impaired level of consciousness, which two factors again cause aspiration, and all this aspiration again leads to the stroke-associated pneumonia. Comorbidities are also a consideration, especially old age, patients with atrial fibrillation and diabetes mellitus, and any pre-existing infection. So risk factors for the stroke-associated pneumonia: more than 65 years, dysarthria or no speech due to aphasia, modified ranking scale of more than or equal to 4, abbreviated mental test score of less than 8, and failed bedside progressive water swallow test. Two or more of these factors correctly predicted pneumonia with 90.9% sensitivity and 75.6% of specificity. Which organisms cause stroke-associated pneumonia? So the most common organisms are Staph aureus, streptococcal pneumonia, and gram-negative bacilli like Klebsiella, E. coli, Pseudomonas, and Acinetobacter. Acinetobacter we see mostly with the environmental conditions, especially when the patients get ventilated. So how do we go about in preventing the stroke-associated pneumonia? So we start with a risk stratification, followed by swallowing function assessment and training, blood sugar control, nutrition support, semi-recumbent position, airway management, feeding management, and medication management. For its stratification, there is again a score which is A2D S2 score. This has the clinical variables, that is age more than 75 years with 1 point, atrial fibrillation with 1 point, dysphagia with 2 points, male sex 1 point, and the NIHSS score of 0 to 4, 0 score, 5 to 15, 3, and more than 16 is 5. And if you see, if this score is more than or equal to 5, then this was there is a prediction of this score, that if it is more than or equal, in 46 patients it was noted, if the score was more than or equal to 5, then 38 patients had the stroke, and if it was less than or equal to 5, 8 patients had the pneumonia. So the predicted value of this score is with a sensitivity of 82.6% and a specificity of 65.7%. And in this, again, there is a modified A2D S2 score, where again fasting hyperglycemia is added, and that also has a scoring of +2. Another score is a risk score to predict hospital-acquired pneumonia after spontaneous intracerebral hemorrhage, and that is known as ICH-APS score. This is ICH-APS-A, which is without the volume of hematoma measured, and B is added, which is added value of hematoma to the score. And the variables include age, smoking, alcohol, pre-stroke dependence with a modified ranking score of more than or equal to 3, GCA score, NIHSS score, dysphagia, infratemporal location, extension into ventricles, and plus minus hematoma volume. The score, if it is 0 to 3, then the risk is very low. If it is 4 to 7, then the risk of acquiring SAP is low. 8 to 11 is intermediate, and 12 to 15 is high, and more than or equal to 16 is very high. This score, again, the sensitivity of this is increases with the length of stay of more than 48 hours. They are valid scores, especially with a stay of more than 48 hours. After finding out with the scoring the risk of developing the SAP, we go ahead with the next important aspect that we come across in our stroke patients, and that is a dysphagia screening. So, in dysphagia screening, in between December 2001 and Jan 2003, 2,532 cases were checked for the dysphagia screening. So, the stroke severity was captured in 1361 patients, and adherence to the dysphagia screening was 61%. The pneumonia rate at sites with a formal dysphagia screen was 2.4% versus 5.4% at sites with no formal screen. If we see, even dysphagia screening is a part of our ASIC guidelines, and class 1 recommendation is dysphagia screening before the patient begins eating, drinking, or receiving oral medications. Then class 2A recommendation is an endoscopic evaluation for those patients where we have a suspicion of aspiration, and it is also reasonable to perform with a by calling a speech therapist or a speech swallow therapist to see whether the patient is at a high risk of dysphagia. And in addition, for the screening, again, a 2B recommendation is we can use either the FES or a video fluoroscopy or a fiber optic endoscopy. And implementation of oral hygiene protocols to reduce the risk of pneumonia is also important. For oropharyngeal dysphagia evaluation, we have to see if the patient has cough plus the high risk, which we have already described in my previous slides. We have to get a evaluation done by the swallow therapist. And if the patient is already having a decreased loss of consciousness, keep the patient NBM. Do not give anything orally. Preferably give a feed tubing. If the patient is alert, then try a swallow test, which is at the bedside, which can be done with just 3 ounces of water. And based on that test, we have to see if the patient is fit for starting oral feeds, and follow the diet, the instructions which are given by the swallow therapist. And if there is any high risk, then we have to go ahead and check for a endoscopy or a FIS. The other guidelines which are also important part is control of the blood sugar, because we have to see to it that the blood sugar is in the range of 140 to 180. Also avoid hypoglycemia, because that also can again decrease the consciousness level, cause aspiration. Nutrition, we have to ensure that these patients are started early on enteral nutrition. We see in most of our patients, if they are not started nutrition on time, then there is a lot of issues. We see them losing weight, we see them, they are not able to cope up with the daily physiotherapy. So we need to see to it that their nutrition is started on time. And in patients who we anticipate will require a longer period where they will not improve, we have to see to it that they go ahead for a peg insertion, so that that becomes more safer. Next is semi-recumbent position, obviously elevation of bed of 30 degrees to 45 degrees, but this decision will be based at the bedside on the clinical parameters, where the nurses have to be trained on this, and preferably this has to be used during the during the enteral feeding, as well as during the swallow test and while feeding the patient orally. Airway management, most important aspect, to ensure that there is a postural drainage of cough, and a chest physiotherapy along with the limb physiotherapy. Perform suctioning regularly so that there is no pulling of secretions. Nasopharyngeal airway, to keep the airway unobstructed in patients with upper airway obstruction caused by tongue falling backward and short neck with obesity. Feeding management, provide soft and thick food such as yogurt for patients who take food orally instead of viscous or thin liquid. Then patients have to be encouraged to swallow a small amount of food each time, which obviously this follow therapist helps us at all the times. Confirming the position of feeding tube before the feeding started, as well as intermittently, the nurses have to keep a check on the mark of the feeding tube. And sometimes if even the tube gets coiled in the mouth. So these are the things which have to be checked at the bedside. And as I already described, that we have to go ahead for a peg insertion for patients who are not expected to recover within a long time. Medication management, reduce the use of glucocorticoids, proton pump inhibitors, H2 receptor blockers, sedatives, and muscle relaxants. Avoid prophylactic use of antibiotics. We have to spare the antibiotics for what is really required, and to avoid antibiotic resistance. Use of ACE inhibitors to control the blood pressure can reduce the risk by increasing the substance P level, promoting the cough, and improving the swallowing reflex. In ventilated patients, follow the ventilator care bundle. That is to prevent VAP. One is head of bed elevation from about approximately more than 30 degrees, daily sedative interruption and assessment of readiness to extubate, then peptic ulcer prophylaxis, DVT prophylaxis, daily oral care with chlorhexidine. In patients who have already developed a pneumonia, we need to see how to start the patients on antibiotics. Preferably see to it that we can send a culture of the sputum or of the endotracheal secretions and empirically start the patient with any of the cephalosporins or the piperacillin tazobactam based on the clinical condition. If the patient is in shock, then you might have to start with higher antibiotics and then de-escalate till we get the reports later and just do a targeted therapy for those patients. Overall, in stroke patients, it is very important that we do a dynamic assessment at admission. I've already told you about the scores that can be used. Check out for the evidence for lung infection, fever, cough, sputum production, and hypoxemia. This is at all points of time. Then if they check the chest x-ray on admission, compare it at different intervals where if you see clinically there is hypoxia or if you see there is increased secretions where we need to repeat a chest x-ray and see if there are any new lesions, then decide, then based on the diagnosis of SAP, check on the investigations further to check, as I told you, to check the cultures, and based on the culture reports, empirically initially you start with the antibiotics and then do a targeted therapy. Overall, for a prevention, it is very important to see to it that the semi-recumbent position, swallowing function assessment and training, airway management, feeding management are done regularly. Thank you.
Thank you, Dr. Darshana. We'll now go to the next topic. It is my pleasure to thank you, Dr. Darshana. Yeah, it's my pleasure to introduce Dr. Nasali Ichapuria, who will be talking on IV thrombolysis, the present, the future. Dr. Ichapuria is the Director of Neurology at Sayadri Hospitals, Pune, pioneer in stroke management with over 1,000 stroke thrombolysis under his belt. He has the distinction of setting up one of the first neuro ICUs and also the ex-president of Maharashtra, president of the Maharashtra and Pune Neurological Societies. He's also a Shanta Padmanabhan Award winner for medical excellence and a stroke preceptor in India and other Southeast Asian countries. Sir, the dais is yours. Please go ahead to deliver your honor.
Thank you. Thank you so much for the very, very kind invitation. And thank you also to HN Hospital and Dr. Arun Shah, who's a dear friend. I'll just share my screen. Yeah. Can you all see it?
Yes, sir.
You can. So today we will be talking on IV thrombolysis, present and future. And I must also acknowledge the help that I've received from my colleagues, Dr. Sanjay Pawar and Dr. Gajanan Patil, who have helped me to produce these slides and to produce this presentation. So, you know, neurology changed dramatically in December 1995. And all this time, we were envying the cardiologists for whatever they were doing in thrombolysis for the heart and putting in catheters and all. And we were struggling. All our trials had failed up to then. And then this trial was published. It had been going on for a few years. The numbers were small, and the trial was difficult because it had to succeed. Had the trial failed, that would have been curtains for this stroke thrombolysis program. So in order for the trial to succeed, there were very rigid inclusion and exclusion criteria, which were then followed on for a number of years. So what has not, sorry. Yep. One sec. Yeah. What has not changed since IVTPA has been introduced? This is now 25 years since it has been introduced, but however, thrombolysis is still underused. Majority of patients who receive TPA have a door-to-needle time of greater than 60 minutes. It's not good enough. And there are ongoing efforts to overcome delays, because reducing RTPA treatment times is the single most important modifiable factor for patient outcomes from hyperacute stroke care. So these are very important milestones that each unit has to achieve over a period of time. So if you look at the Indian statistics, they're frightening. You know, we have in India estimated 1.5 million strokes every year. That is 3,000 to 4,000 strokes every day in India. And how many thrombolysis have we done? We have done less than 20,000 thrombolysis per year. That means we've covered only 5 days of the year. So January 1 to January 5, and the rest of the time, there's nothing. So we have a long way to go, and to make this IV thrombolysis a uniform standard practice all across the country. It's a gigantic task, but the growth rate is 30% per year. So the companies are very happy that we are growing at 30%, but still, it's just so small. And if you see the interventions, there were less than 1,000 interventions in the whole year. So for mechanical thrombectomy, less than 1,000 per year. So what is the situation in India? First thrombolysis for stroke in India happened in 1998-99. As of 2007, only 15 centers were thrombolizing for acute ischemic stroke. And in 2018, more than 500 centers were thrombolizing stroke patients in India, and 60 centers were capable of performing intra-arterial or mechanical thrombectomy. So still the numbers are very small, and we have a long way to go. So what has happened in 25 years in India and across the world, of course? It has changed neuroscience. As I told you, what neuroscience we learned as students has drastically changed. And many things have changed in movement disorders, in epilepsy, in dementia. Everything has changed. But according to me, the biggest change has been in stroke treatment. And this has been brought about by a birth of a new specialty, new devices, something which we never thought of: monumental research, drug discovery, and imaging. Where was the imaging 20, 30 years ago? And we will talk a little bit on imaging also, and look at what imaging we can do now. The challenges that we face in our country is how to make it universally available, affordable, and accessible. The 3 A's, very important. Most of the treatments are very expensive. Many people cannot afford them. They have less accessibility because there are very few stroke centers, and the treatment is not available universally across the country. So this is our big challenge for the future, of how to get the 3 A's into place. What has also happened is improved diagnosis has occurred, transport systems have changed, emergency care has changed, stroke scales have come, imaging modalities have drastically changed. The response times, were very high. They're coming down rapidly. And now we are able to achieve thrombolysis in many cases in less than 30 minutes. And the concept of stroke units and stroke centers has come, which was not there previously. But to do all this, you need a team to win. You need a team, and you need all these team members. All of them have to row in unison. All of them have to row in unison. But at the end, you need a stroke champion. You need a leader. So every hospital should have a stroke leader or a stroke champion who controls the entire team. And thrombolysis, you need teamwork. You can't do it alone. It's impossible. You can't work 365 days a year, 24 hours. You can't, it's impossible. So you have to develop a team in order to succeed. And to do IV thrombolysis, it requires a team of at least 4 or 5 people. And maybe to do mechanical thrombectomy, you need 10 to 15 people to do mechanical thrombectomy. So you need to develop a team. Every hospital, unfortunately, many people are working solo. And because of that, they are not able to achieve the results that we really need. So we really urge everyone in every small hospital or big hospital to produce stroke teams and to address this challenge. So what am I going to talk about? So the outline of the talk would be how we have extended the time window. You know, initially we were very rigid. As I told you, the trial had to succeed. So there was tremendous rigidity in all the criteria. There are advances. Then we will talk a little bit on advances, not all, because I'm not a radiologist, but a few advances in radiology. We have to widen the indications and decrease the contraindications. One of the major setbacks for IV thrombolysis, why it didn't take off, was that there were too many indications and too many contraindications, and it was very difficult for people to remember these and to achieve these. We'll talk a little bit about new drugs, and we will talk in brief about telestroke and pre-hospital care. Now, talking of extending the time window. Now, we know this graph, and I've shown this, and everyone has shown this thousands of times. But it is this particular drug, this particular drug, Actylase or TPA, it's a very funny drug. It acts very well if it is given early. But as time goes on, as you go on, the efficacy goes down and down. And if you look at it here, if you give it in the first 90 minutes, the number needed to treat for a good outcome is 5, and the absolute and the absolute risk reduction is 20%. But as time goes on, the number needed to treat for a good outcome increases, and the absolute risk reduction is lower. But if you see this graph carefully, this is the average, the standard, the run-of-the-mill patient. But there are outliers. You know, there are outliers. Look at this blue line here. So, you know, some patients can even benefit later, even at 330 minutes, 360 minutes, and the line goes on. And then there are some patients who do badly. They do well in the first, but they don't do well later on. So there are a few outliers, but the general trend is that after about 270 minutes or 300 minutes, the drug does not work so well. So therefore, why we need a stroke team, why we need to reduce stroke the door-to-needle times, why we need to get good transport systems, good imaging systems, quick imaging systems, is because of this particular graph. So for many years, it was 3 hours. But 3 hours, you know, we could treat very few patients. And, you know, the public health awareness was not there. The awareness in the hospitals was lacking. There were very few stroke champions. So it was a really uphill task to do stroke thrombolysis in the beginning. But in 2008, this paper came. This is the ECAS-3 trial, and thrombolysis with alteplase, 3 to 4.5 hours. Even then, there were a lot of caveats. You couldn't do it in people above the age of 80. You couldn't do it if they had blood pressure, or they couldn't do it if they were diabetic. You know, there were too many of those, and that created a lot of problem. So we've been able to whittle down all those contraindications to a very, very large extent. Yeah. Now, so many of our patients, 25% of our patients, they come with an unknown time of symptom onset. We don't know when he was last normal. And these patients were excluded from IVT, intravenous thrombolysis. However, many patients with unknown stroke onset could benefit from this treatment, and here imaging could be helpful. So here imaging came in, and many multicentral observational studies, still observational, not very big studies, with unknown time of onset, showing a diffusion flare mismatch defined by positive findings on the DWI scan and negative findings on the flare scan, were effective in identifying patients within 4.5 hours of symptom onset. So this was the paper. This was the wake up stroke trial. So many of our patients, they woke up with a stroke, and therefore we didn't know what the time onset was. And then, many elderly people were living alone, and they got a stroke, and they couldn't tell us when the time was, and therefore this trial was extremely useful. So what does it show? It shows that IV alteplase can be beneficial in patients who awake from a stroke or have unclear time of onset greater than 4.5 hours, and if a DWI MRI lesion is less than 1/3 of the MCA territory and no change on the flare. So this I will show you. So this very beautifully, it shows that you do an MRI scan and it shows a DWI lesion, but no lesion on the flare. So it shows a smallish infarct, not a big infarct. It shouldn't be more than 1/3 of the MCA, and nothing should be seen on the flare. And similarly here, you see a lesion on the DWI, but nothing on the flare. So this type of patient, you can take up for IV thrombolysis, and the treatments are better even if you don't know the time of onset. And this shows that there is no flare mismatch. So there is a diffusion lesion here, and there's a lesion on the flare. This is another patient. It shows a diffusion lesion here, and the same or similar lesion is there on flare. So you cannot take these patients. So if there is no DWI flare mismatch, you cannot take these patients, but the above patients you could take, and these patients benefit by IV thrombolysis. So even though you don't know the time of onset. Now, we want to go one step further, and this is IV thrombolysis guided by perfusion imaging up to 9 hours after the onset of stroke. So now we've gone from 4.5 hours and unknown time of onset to up to 9 hours. So this study was done in Australia by Bruce Campbell and his colleagues, of course, and this was called the Extend trial. And what it showed was that if you have on CT or MRI a perfusion core penumbra mismatch, only then can you, and mechanical thrombectomy is not planned, you can give alteplase over no alteplase. The quality of evidence is moderate, the strength of recommendation is weak, but yes, some patients would benefit. But you don't do it if you don't have advanced imaging. If you can't do an advanced diffusion perfusion MRI or a CT perfusion scan, if you can't do it, if you don't have the facilities or you don't have the knowledge to do it, you should not give this particular treatment. So if you do just a normal MRI or a normal CT scan, then we do not advise you to give alteplase. But if you have those facilities, you can extend the window up to 9 hours. So this is another very major advance which has occurred over the last few years, and this is also now the future. Now the big breakthroughs in stroke management and stroke thrombolysis has come in advances in radiology. Now we'll go through this very briefly. So you have this patient, this is an eternal question. Everyone asks me every time that, hemiparetic patient, will you do CT scan or will you do MRI? So, so what's the answer? So most places in the world, within the window, within the 3 to 4 hours, do a non-contrast CT scan. This is preferable to MRI. Now, in India, unfortunately, I don't know, most people are doing MRIs rather than CT scans, but we will talk about that a little later. CT angio or MR angio in most cases. So in almost every case, we would do a CT angio or an MR angio, especially if the NIHSS is more than 6. Initially, we used to say 9, 10, 12, when it was a major stroke, but we brought it down now to 6. So there's hardly any patient we don't do a CT angio or an MR angio. Intervention is not possible without vascular imaging. So if you have a good intervention center, you have to do vascular imaging, and without that, it is not possible. As I told you, wake-up stroke or stroke of uncertain onset time, that's 20 to 30% of strokes, here we would prefer to do an MRI showing a diffusion flare mismatch. It's also very useful for small strokes, which cannot be picked up on CT scan. Posterior fossa stroke, small strokes in posterior fossa, MRI is preferable. And if you're using the Dawn criteria, which I'm sure the interventionists will talk about, I'm not going to talk much about that. If you're using the Dawn or diffuse criteria, where you can go up to 24 hours for mechanical thrombectomy. So see how the window has expanded. So you can go up to 24 hours if you're doing intervention. And here, here you need an MR or CT perfusion study for core size and mismatch. So this is the type of imaging that you would like to do. Now, another very, very important thing that the CT angio can tell you, which an MR angio cannot tell you so easily, is the collateral circulation. So look at this here. There are very poor collaterals here. So you do a CT angio and then you do a 3-phase CT scan, and you find that this patient has very, very poor collaterals. And what really happens here is that you get a large infarct. You get a large infarct because it is not supported. The MCI occlusion or the internal carotid occlusion is not supported by collaterals, and invariably you land up with a very big infarct. If there are intermediate, look at these intermediate collaterals here. So you would land up with a smaller infarct. And if you're blessed with large number of collaterals, now I don't know why some people have collaterals which are large, maybe preconditioning, I don't know what the reason is, but whatever it is, if you have large number of collaterals, look at the collaterals here, look at the collaterals here, look at the collaterals here. If you have large collaterals, the carotid occlusion will be supported and for a longer time, and you will land up with a smaller infarct. So CT angio, again here, is very, very important, and it can tell you the collateral flow. So early time, but poor collaterals, these are the poor outcomes or the fast progressors. Now you saw that graph right in the beginning, the bottom red line, which is a fast progressor, they don't do well because they have poor collaterals. And late time, but you have good collaterals, these are the slow progressors, and they do reasonably well. And then you have these specialized studies where you do perfusion scans, or you see the cerebral blood flow, cerebral blood volume, or the Tmax. And now you see this patient, he has very poor collaterals here, very, very poor collaterals here, and he lands up with a large defect like this and a big infarct. And you see this patient here, he's got good collaterals, and the perfusion defect is large, but the infarct is small. There's a small infarct, but a large perfusion defect. And then if you open up this vessel, he lands up with a small infarct. So this is the advantage of advanced imaging. Another important point, you see this now. Here the scan looks normal. It's small diffusion lesions here. So on ADC also small, but you see these large veins here. So on SWI, you see these large veins here. This can tell you that there is a large penumbra. So even without doing a perfusion scan, you can see this. If you do an SWI image, you can see these large veins here, and this can tell you, compare it on this side and this side. And here you can see the large perfusion defect and a small infarct with a large perfusion defect. So these patients can also do well. But these are all very, very complicated, very difficult. You've got to call the radiologist. The radiologists don't come in time. It all wastes time. So now we have a very good automated system called the rapid MRI. So you just put that software. It is AI, artificial intelligence. You just put that software into your CT scan or MRI machine, and it gives you a color-coded picture. Where is the perfusion? Now you see this, sorry. You see this. small diffusion lesion here, large perfusion defect. So in color coding, it tells you in a minute or two, ki, "Arey Baba, this fellow has got a large perfusion defect, small core. This is a patient directly. You take him up for mechanical thrombectomy." And this thing you can do with CT scan also. Same thing. Small defect here, core, and large perfusion defect. So this is AI. So this is the thing. It integrates all the cerebral blood flow, cerebral blood volume, the mean transit time. You don't have to remember all those things. I have great difficulty in remembering all those things. So this thing just very easily in a minute or two tells you the entire answer. Now all of us argue on this point. Should we do CT scan or should we do MRI? Now, look at this evidence. CT scan, it is quick, easy to do and read, available everywhere. It rules out hemorrhage much more efficiently. Metals, movement, and sedation, these are the big drawbacks of MRI. So most patients are restless, they have to be sedated, they move, they have metal in their body, somewhere in their teeth or in their head, or a pacemaker, so you have to do all that work. CT angio, as I told you, can assess collaterals well and clot length well. Clot length is also very important, whether these patients will do well with IV thrombolysis or you need mechanical thrombectomy. CT perfusion can be done easily. Rapid software can be incorporated easily. It's a little expensive, so everyone doesn't have it. But if you have the money, if your hospital has the money, they can do it. Centers which do CT scan have larger number of eligible patients and lower door-to-needle times. There's no doubt about this fact. And many centers in North America and in Europe do CT scan, especially Calgary, and many centers do CT scan compared to MRI because it lowers door-to-needle time and gives larger number of eligible patients. However, MRI is invaluable in quite a few cases, posterior fossa, mimics, late time window. So use both judiciously. No place for being adamant. Whatever you're comfortable with, use, but these are the points in favor and against. So I will not argue or be adamant that you use this or that. Use whatever you have. Now, as I told you, these initial trials, the NIMS trial, yeah.
Yeah. No, you're not unmuted. Is it disconnected? Nestle, you are muted. I can see your this thing.
Yeah,
Now you are unmuted. Correct.
yeah,
Very good.
yeah.
Now you share your screen.
Yeah. Sorry for that.
Share your screen now.
Yes. Just a second. Yeah, you can hear me, no?
You made your presentation and slideshow. Just make it slideshow.
Yes, sir, we can.
We
Yeah,
can
I'm
hear you.
trying to do that.
Slide
I'm trying
is
to do that, yeah. Something's happened.
No, I think you just have to press slideshow. That should be sufficient.
I think by mistake you might have deleted this thing, sir. Just you may have to go back on the.
Yeah, I can hear you. Can you hear me?
Yes,
yeah, we can hear you.
can.
Yeah.
We-
Okay,
You
fine.
reduce your magnification on the lower right side. Yeah.
Yeah. So
but the
now
slide,
you can hear?
No,
we
I
can hear
think
you.
Leslie, you have magnified your slide, so you'll have to go down to the lower right side and reduce the magnification. There is a bar there for magnification. Right hand side corner of your screen, low down.
I can't see anything there.
No, it's just the bar there, vertical bar.
Okay, you can't see anything?
No, we can't because you have magnified too much, so everything is going out of the screen.
Okay, wait a sec.
You can
Yes,
press on.
I'm doing it.
Yes. Hmm.
That's perfect.
Okay?
Yes. Yeah,
Is
we
it
can
okay?
hear you and see you. Yes,
Yeah.
sir.
Yeah. So sorry for that. So as I told you, we have to widen the indications and decrease the contraindications. And therefore, what are the inclusion criteria? Any stroke more than 18 years and the CT MRI is negative for hemorrhage. That is the indication. Okay. You just need to rule out hemorrhage. You just need to this thing. So exclusion criteria means has bled or may bleed. So if there is ICH on the scan or SAH or active internal bleeding or major bleeding in last 14 days or surgery has been done or recent ICH, AVM or aneurysmal SH, which is unsecured. And if BP cannot be controlled with drugs very rapidly, these are the contraindications. But there are no other contraindications. So has bled or may bleed. These things you are worried about, and therefore you will proceed with the this thing. And there are discussions that should we use IVT in acute stroke patients before thrombectomy, in lacunar stroke, or in no visible large artery occlusion. There is currently no strong evidence that it should be avoided. So you can use it in lacunar stroke, you can use it before thrombectomy, and you can use it even if you don't see an occluded vessel, but the patient is hemiparetic and he has a stroke. So these are the main inclusion and exclusion criteria. Now every stroke is different, every patient is different. So, we get confused. So what are the recommendations now? Very quickly, we'll go through it. Mild but disabling stroke symptoms. What do you mean by mild? NIHSS less than 4 or 5. But it is disabling. He's got aphasia. He's got hemianopia. He's got a useless hand. He's got a Gerstmann syndrome. Highly disabling. But if you do the NIHSS, it comes as a minor stroke because the NIHSS comes to 2, 3, 4. So these patients also IV TPAs to be given up to 4.5 hours. If it is a minor non-disabling stroke, minor, that means mild facial weakness, mild sensory impairment, and then maybe you would not give because the evidence does not show that it gives benefit and it may produce a little risk of hemorrhage. So don't give it in very mild non-disabling strokes. Now, another problem, minor non-disabling stroke with large vessel occlusion. So again, there is no proper data, but expert opinion would recommend IV thrombolysis or even mechanical thrombectomy if you find a large vessel occlusion with minor disabling stroke. So no definite evidence. This is just expert opinion. Then you have patients, who are rapidly improving, but they are still disabled. So when you see him in the casualty, his power is grade 0, but after some time you find that his power has come to grade 3 after you've done the CT scan or MRI. So you're wondering, he's improving, so should I give or not? But if it is not improved completely, you should give. So evidence is in favor of giving IV TPA. Now, another very common question asked is it's a big stroke and there are early ischemic changes greater than 1/3 of the MCA. What is the contraindication? Well-established infarct is the contraindication greater than 1/3 MCA. But early ischemic changes, that means aspect score is low, below 7 also. This is not a contraindication. So IVT is recommended, but consider other factors like mechanical thrombectomy, advanced imaging, collaterals, and make a decision. So data is a little not so good on this, and patients may not do so well, and you may have to do more advanced imaging, but definitely it is not a contraindication. So, we've had this discussion umpteen times whether we should do it or not, but we should, okay? Then seizure at onset. Yep, sorry. Seizure at onset. At one time, seizure at onset was supposed to be a contraindication. But if seizure at onset is secondary to a stroke, and you're sure that it is because of a stroke, you can thrombolyze this patient. Blood sugar, initially it was a contraindication if sugar was less than 50 or more than 400. But if you normalize them and still there is deficit, these patients also you can thrombolyze. Coagulopathy. Right, sorry. Coagulopathy. If the patient is on warfarin and the PT-INR is less than 15 seconds or less than 1.5 INR, 1.7 INR, you can thrombolyze. If there is coagulopathy, of course, you consider on a case-to-case basis, you talk to the hematologist, and then, it's very rare to see this. You rarely see a hemophilia getting a stroke. In fact, I've never seen. So really, I don't know whether this really comes true. Recent major trauma. If it is not involving the head, If there is no major bleeding, say a fracture neck femur has occurred, and the patient is in bed, and he's been operated, and now he gets a stroke, not uncommon, not uncommon. But if the thing is secured well and he's not likely to bleed, then yes, you can thrombolize such a patient. Recent major surgery, it depends. If it is within the preceding 14 days, you will be careful and you anticipate bleeding, then of course you don't give. Say a bypass has been done. Menstruation. If the patient is actively menstruating, you can give, you should give. If there's active vaginal bleeding with significant anemia, then you consult a gynecologist and take an opinion. If there is significant anemia, then maybe you'll have to think your decision. Okay. Unruptured intracranial aneurysm. You can give thrombolysis, moderate, small or moderate size, less than 10 millimeter in size. If it is a large unruptured aneurysm, then no, perhaps no. But if it is a small aneurysm which is unbled, or an aneurysm which has been secured by coiling or by clipping in the past, you can give IV thrombolysis. Intracranial vascular malformation, AVM, which is unruptured, probably not. Probably you would not give because the risk of hemorrhage is more. But if you think that the stroke is severe and this, then maybe you would think of it. But by and large, no. This is a risk, so don't give it. Recent MI, not uncommon scenario. So if the MI, oops, sorry. Yeah. If the MI was non-STEMI, that means ST elevation was not there, it was subendocardial infarct, you can give even within the first 3 months. If it was a STEMI involving the right or inferior myocardium, you can give even if it is early within the first 3 months. If it is a STEMI involving the left anterior myocardium, then you have to be a little careful. Maybe you would do some more tests like echo, success of cardiac recanalization therapies, size of the myocardial damage. You consider all these factors, and then it's not an absolute contraindication by no measure, and you can give. What was the risk? The risk was that cardiac tamponade would occur, and this would kill the patient. But only 5 or 6 patients in the world literature really have got cardiac tamponade after MI and thrombolysis. So really, it's a very, very small risk. Left atrial or left ventricular thrombus. What do you do in such a case? If there is severe disability and known left ventricular or left atrial thrombus, you can give IV alteplase. But if the disability is mild, then it has an uncertain net benefit because there is a risk of clot disruption and clot embolization. So if the stroke is large and severe, then you can give because there will be a net benefit. But if it is a mild stroke, then perhaps not. If the patient has malignancy, even if the patient has malignancy and if his life expectancy is more than 6 months, you can give. Malignant patients with malignancy have more risk of stroke because of the procoagulant state. So you may want to give in these patients. Pregnancy. Pregnancy is also not a contraindication and there may be benefit. We'll talk a little bit about that. Stroke mimics. Now, stroke mimics always gives you a lot of trouble. But, migraine, which are the other stroke mimics? Migraine is the commonest stroke mimic. Seizure at onset, functional, my God, functional hemiparesis, functional aphasia, functional dysarthria. All of these give you a tough time. But even if you give in stroke mimics and it is not actually a stroke, it is safe. And it may be recommended in preference to delaying treatment to pursue additional diagnostic studies. So it may be even beneficial in stroke mimics. And now these old things that, greater than 80 years was a contraindication. No longer. Warfare in use. If it is less than 1.7, you can give. And previous stroke or diabetes was contraindication previously. Now it is no longer a contraindication. So all these contraindications have been thrown out of the window. Okay, so let's not go into this. So what is the recanalization with IVT? So if you have a ICA occlusion, then the recanalization rate is very low. You have to do mechanical thrombectomy. There's no doubt, because recanalization is only 4.5 or maybe 10%. MCA, 32%. 32% MCA do open up. It's surprising, but they do. So therefore, many people recommend, and even I do, that you give IV thrombolysis prior to this, and some patients do respond, and you don't have to do mechanical thrombectomy. You don't wait, of course, but M2, this figure seems a little low to me, 30, maybe a little more, and basilar is low. I think 4% is too low, but anyway, whatever, this is from this thing. And the ideal cases, that is the sweet spot, is a branch occlusion where the NIHSS is 5 to 15. This is the sweet spot for IV thrombolysis. And if you get a patient of this type, he will do very well if you give thrombolysis with low door to needle time. So these are the ideal cases to take, and this would be the approximate recanalization rate. Now, another problem, central retinal artery occlusion. You see a few patients, they suddenly become blind, that there is higher likelihood of a favorable visual outcome if you give IV TPA. This is 37% compared to 17%. So in central artery occlusion also, this is not a study, this is just one study, this is just one report in the literature, but it is a pointer that it may be good if you give it early. And now you have this tenecteplase, more specific clot binding, greater efficacy in large vessel occlusions, IV bolus. Trials have been done, and the cost is lesser in India, approved for use in India in 2016, and many people have been using it, and they find it very convenient because you have to use a single bolus. And in India, in 2019, 4,700 cases were administered. Dosage was not uniform, going from 0.2 to 0.4 milligram per kilogram. But now occlusion within 4.5 hours who are candidates for MT, and the dose recommended is 0.25 milligram per kilogram, and this is preferred over TPA. So this has been a major new change for tenecteplase, and it is much easier to give, and in India the cost is lesser. And now very quickly we just go through this telestroke. This telestroke is very important, and we use it regularly, even in big cities with traffic problems and difficulty in reaching the hospital in time, and of course for the rural areas where doctors are limited and people are not so good with thrombolysis. If you use telestroke, and it has been found, this I won't go through all this, but community physicians, we want to increase our thrombolysis rates, so community physicians should be allowed to do thrombolysis with consultation with a stroke specialist or a neurologist. And in Himachal Pradesh, this has been done in 2014. And you will be surprised to note that the first patient was done at a district hospital without the presence of a neurologist by an orthopedic surgeon. The first IV thrombolysis by telestroke was done by orthopedic surgeon, and till date 150 patients have been done. And we also have this stroke WhatsApp group, is telemedicine, and we have done this pregnant lady, she had twins, and she was in a village 180 kilometers from Pune. She delivered twins next month normally. She was successfully thrombolized. So this is how telestroke medicine works, and this is why it's so important. Another thing, we must form stroke units. We must have a multidisciplinary approach. And I've been shouting from the rooftops that we should have certification for stroke units into specialized stroke unit, primary stroke unit, thrombolytic stroke unit, but somehow this has not happened in our country. So this is the future, and I'm very much looking forward to it, to get accredited, various stroke units to get accredited. And now we have these mobile stroke units. There are 3 in India already. Their ambulances are equipped with a portable CT scan and digital technology. So you give the thrombolysis, you do the CT scan in the ambulance and give the IV thrombolysis in the ambulance. So the door to needle time is now not door of the casualty department, but the door of the patient's home. And it's very expensive. It costs 8 crore rupees in Indian rupees today. So therefore, many people cannot afford it. And it is not commercially viable. Because it's not commercially viable, it's not being used so much. But in some rich countries and some densely populated neighborhoods, this is a very useful tool, and this is the future of mobile stroke, this thing. So thank you so much. I've overshot my time, but sorry for that.
Thank you, sir. It was a wonderful lecture and really in giving insights into the future and what we know about stroke. So I think with this, we come to the end of this session. I will hand over the proceedings to the next chairperson and back to the coordinator. Thank you very much, sir.
Thank you, sir.
Beautiful.
Yeah.
Very good.
Thank you, Dr. Sunil Karan. Thank you, Dr. Snehal Sangvi, sir, for being a part of the session. We'll go ahead with our last session, session 4. The chairpersons are Dr. Pradyumna Oak. He has passed his DM from Nair in 2002. He's worked at Nair as lecturer and then as lecturer and professor at St. GS Medical College and KM Hospital. He did fellowship in interventional neurology with Dr. Anand Alurkar at Pune, presently working as head and director of neurology at Nanavati Super Speciality Hospital. Instrumental in getting first hub and spoke model of rapid AI software in India at Nanavati Hospital. Special interest in stroke and neurointervention. The second chairperson is Dr. Arun B. Shah. Arun Shah sir is a consultant neurologist, PG teacher and director of the Department of Neurosciences at Sir H.N. Reliance Foundation Hospital and Research Center, and has been in clinical practice for 36 years with special interest in stroke, dementia, neurocritical care and multiple sclerosis. After completing his DM, he completed a fellowship in stroke and vascular neurology at the OHSU, Portland, Oregon, USA. He directs the acute stroke program at the Stroke Ready Sir H.N. Reliance Foundation Hospital and offers holistic care to patients at the MS clinic, including the latest disease-modifying therapy. I'll invite Dr. Pradyumna to introduce the next speaker.
Hello, good evening, everyone. Am I audible?
Yes, little louder.
Yeah. Good evening, everyone. It's pleasure to introduce Dr. Abha Shah. I have worked briefly with her when she was in India and she was intern at H.N. Hospital. She has completed her neurology residency at Albert Einstein Beth Israel Medical Center in New York, where she was a chief resident. Dr. Abha Shah did her vascular neurology fellowship at prestigious National Institute of Health, Bethesda, USA, after completing her residency. And currently she serves as the stroke director and attending neurologist at MedStar Southern Maryland Hospital and part of neurology faculty at MedStar Georgetown Department of Neurology since 2015. Welcome, Dr. Abha Shah. Over to you.
Thank you, Dr. Oak. Good to see you again after so many years. Thanks for the nice introduction. Just trying to share my screen. Is my screen visible? I'd like to thank Dr. A.B. Shah and Dr. Patel for inviting me to give this talk for this wonderful seminar that has been organized. I'm going to touch upon blood pressure management in acute ischemic stroke. I do not have any disclosures. So during this talk, I'm going to briefly talk about the background and pathophysiology of blood pressure as it relates to acute stroke, blood pressure management in the different phases of an acute stroke, and then briefly discuss blood pressure management in the post-stroke period for secondary stroke prevention. So as we know, stroke is one of the leading causes of death and disability globally, and about 90% of strokes are preventable and are attributable to 10 modifiable risk factors. Hypertension being one of the major modifiable risk factor, which accounts for a very large proportion of strokes in both developed and developing countries. Just to briefly remind everybody about cerebral autoregulation, which is a process by which a steady cerebral blood flow is maintained despite fluctuations in the systemic blood pressure. And an unimpaired cerebral autoregulation is important to maintain steady cerebral perfusion. However, in the setting of an acute stroke, the autoregulation can be impaired, especially if it's a large vessel occlusion. And when there is an impaired autoregulation beneath the lower limits of autoregulation, as you can see, the limits are between 50 and 150 millimeters of MAP, there is either decreased cerebral perfusion leading to hypoperfusion and extension of strokes. And if there is higher blood pressures, it can lead to cerebral edema due to hyperperfusion. In patients who have chronic hypertension, this autoregulatory curve is shifted to the right over time. And therefore, these patients already have an impaired tolerance to any type of acute hypotension, which is more compounded if the patient is coming in with an acute stroke with more superimposed altered autoregulation. Another important pathophysiologic event that occurs in the setting of an acute stroke is the acute hypertensive response. This is seen very commonly in about 80% of patients who have acute ischemic strokes. And a lot of these patients, about 20%, do not have any prior history of high blood pressure. This is a self-limiting process, and blood pressure spontaneously reduces within 10 days after a stroke, but it is prognostically significant. So very high blood pressure in the first few days or hours after a stroke does have an increased risk of death or dependency and clinical deterioration. Causes are probably underlying and undetected hypertension that was not treated. And then there are certain stroke-specific mechanisms which may account for the response that is seen in patients that do not have hypertension. And these might include damage to the brain structures that are involved in regulation of cardiovascular functions, such as the insula, which can be involved. And then stress response to hospitalization, which we commonly see is like patients have urinary retention or just being in the hospital emergency room environment can cause their blood pressures to be elevated. So we know that baseline blood pressure has an effect on outcomes after a stroke. And in the International Stroke Trial, which looked at more than 17,000 patients, there was a U-shaped relationship that was seen between the baseline blood pressure and outcomes, with very high blood pressures resulting in more cerebral edema. Patients who had blood pressures that were over 200 millimeters of mercury were more likely to, about 50% of them develop symptomatic ICH. And on the other hand, very low blood pressures were associated with more worse clinical strokes, as well as more acute coronary events and deaths due to that. So definitely there is a balance that needs to be aimed for in the acute setting when managing blood pressure. So I mainly want to focus in this talk on the fact that blood pressure management in an acute stroke is a very dynamic process, and it depends on a variety of things. Just to simplify it, we try to divide it into two phases. The phase of an acute stroke, which is prior to reperfusion. So this is the acute phase to the left of the figure, where you have an acute arterial occlusion, which has occurred. And the goal for us is to protect the ischemic penumbra. During this phase, we do not want to have very high or low blood pressures, and we'll talk about that in a few minutes. The second half of this acute phase is a little more unpredictable because it depends on whether reperfusion is achieved. And most of the times, we do not know whether reperfusion is achieved or when it is achieved or to what degree it is achieved. So during this phase, our goal is to prevent symptomatic ICH. and prevent stroke extension to optimize the best outcome for the patient. So coming to BP therapeutic targets, which is what we basically practically want to know, I'm going to divide this into 3 phases. So the initial assessment is when the patient first comes in with an acute stroke. And then we'll talk about during recanalization and after reperfusion treatment. So coming back to our figure, the initial assessment is when we have an acute stroke occurring, either because of a large vessel arterial occlusion or any other type of acute ischemic stroke. The goal is to protect the ischemic penumbra. The ischemic penumbra, as we know, is salvageable brain tissue, which has a competent collateral circulation. And our goal is to, save this tissue by recanalizing and reperfusing that part of the brain. And so we optimize collateral flow by achieving therapeutic blood pressure targets, also avoiding extremes in changes of blood pressure, given that there is impaired autoregulation. If you have hypotensive episodes, you're going to have stroke extension. So do we have any idea of what the therapeutic targets need to be in this acute phase? So there have been many studies that have been performed over the years, which have looked at a variety of agents, including nitroglycerin, ACE inhibitors, beta blockers. They've also looked at administering the treatment at various time points in an acute stroke setting. So very early administration by paramedics in the field within the first 4 hours, up to 48 hours, and then going into 7 days. And then also using various different parameters of blood pressure. So reducing by 10 to 15%, reducing if the blood pressure is over 120 or over 140. And there was actually no difference that was found in the 90-day modified Rankin scores or death in most of these studies. And in fact, some of the studies actually showed that there was increased risk of death, especially in the beta blocker study, which showed that there was increased risk of mortality in the treatment group. So unfortunately, we don't have any sufficient evidence that lowering blood pressure in the acute phase of a stroke does actually improve functional outcome. There is no evidence to date that there is any reduction in death or dependency, either by the class of drug use, the type of stroke the patient has, or the time to treatment. So what do we do practically? So we start with correcting hypotension and hypovolemia. Again, there is a paucity of evidence regarding what type of pressors or crystalloids or colloids that should be used, how long this should be continued, or what the volume should be. But if a patient is coming in with a stroke and is hypotensive or hypovolemic, we correct that. And we try to investigate what the etiology is, whether it's related to some sort of a cardiac abnormality that they're presenting with low blood pressures. Then we look into whether the patient is a candidate for IV thrombolysis, if they're presenting within the appropriate time window, or if they're a candidate for endovascular treatment. We lower blood pressure to less than 185 over 110 prior to treatment. And this is extrapolated from the NINSAR TPA trial and has been shown in other retrospective studies to also be beneficial, because higher blood pressures in this goal had resulted in more hemorrhagic transformations in patients. If they are not candidates for acute reperfusion therapies, that is IV thrombolysis or intra-arterial therapies, permissive hypertension should be allowed for up to 220/110 for at least 24 hours. And the aim is to protect the cerebral perfusion. Now, of course, there are some exclusions to this, and we'll talk about that in a second. What antihypertensives can be used in the acute setting? Commonly used are boluses of beta blocker labetalol and hydralazine. And these medications work pretty quickly. There is some data that hydralazine actually causes increased intracranial pressures, but you might be encountered by a patient who's actually bradycardic and you cannot use labetalol. So then your next choice would be hydralazine, and you can use this with caution. Also, continuous infusions of calcium channel blockers like nicardipine and clevidipine. These are very helpful. These medications have minimal effect on the cerebral blood flow. They're also very fast acting and easily titrated and very commonly used in the emergency room. You can see I crossed out enalapril, which is an ACE inhibitor. So in a patient that is an IV TPA candidate, we do not want to give ACE inhibitors because of a risk of angioedema, which can be life-threatening in these cases. So moving on to blood pressure targets that need to be maintained during recanalization. And this is specifically going to talk about intra-arterial therapy. We don't have a lot of data or actual studies on this, but we do know that elevated blood pressure during intra-arterial therapy is associated with worse outcomes. And similarly, very significant intra-procedural drops in blood pressure are also strongly correlated with worse outcomes. General anesthesia and conscious sedation, this has been a discussion in terms of intra-arterial therapy. There's a concern that with more drops and fluctuations in MAP, there might be worse outcomes, and this can be seen in patients who undergo general anesthesia. However, there were two recent clinical trials, Siesta and Golia, where they did show that general anesthesia was associated with more drops in mean arterial pressure. However, when compared to conscious sedation, there were no very significant or sustained drops in the blood pressure, which they defined as MAP drops of greater than 40% or a sustained MAP of less than 70 millimeters of mercury. So practically speaking, the Society of Neuroscience and Anesthesiology recommends that systolic blood pressures be maintained between 140 and 180 millimeters of mercury during the intra-arterial procedure. Both general anesthesia and conscious sedation are reasonable for intra-arterial therapy. The important thing is to maintain vigilance and have strict protocols to maintain the systolic blood pressure in that range and MAPs more than 70. Finally, talking about blood pressure therapeutic targets after reperfusion treatment. So we come back to our figure where we have divided our stroke into two phases. This is again, like I said, a very unpredictable and unsure time after in the stroke patient. We do not know if reperfusion is achieved unless the patient underwent intra-arterial therapy, in which case we have some idea of the vessel status. But in patients who undergo IV thrombolysis or those that are not candidate for reperfusion therapies, we don't really know when reperfusion occurs or to what degree it occurs. And so in the first group where we know the reperfusion status, our goal is to, or our focus should be to prevent further damage to the injured vascular bed and avoid elevated blood pressures. And the same applies to patients who received IV TPA. We do not want, if there's recanalization achieved, we don't want them to have elevated blood pressures. On the other hand, when we're not sure about the reperfusion status, we don't want the stroke to extend by dropping the blood pressure and impairing cerebral perfusion. So this is a very tricky time. And this is usually in the first 24 to 48 hours after a patient presents. So the guidelines suggest that blood pressure should be maintained less than 180/105 for the first 24 hours after IV TPA. Because we don't know what the reperfusion status is. And extrapolated from the TPA trials, all the patients that underwent endovascular therapy in the clinical trials also had the same blood pressure goals of less than 180/105 after recanalization was achieved. However, we can estimate that if a complete or near complete recanalization is achieved, that is if there is a TICI 2B to 3, then a higher blood pressure close to 180/105 could be associated with increased risk of reperfusion injury. And so this was looked at in this study with in the SITS registry, where they had patients who were recanalized, and they found that the modified Rankin score was patients who had higher blood pressures, especially greater than 160 after recanalization, were less likely to have good outcomes. And also they found that the symptomatic ICH rates were much higher in both the recanalized and the non-recanalized patients if their blood pressures were greater than 160 after recanalization, or in the non-recanalized group as well. This was another study that looked at about 1245 patients who had anterior circulation large vessel occlusions, and they underwent successful mechanical thrombectomies with TICI 2B or greater recanalization. And they showed that the mean systolic blood pressure range, as well as the maximal systolic blood pressure, correlated with increased risk of symptomatic ICH. These graphs are showing the mean systolic blood pressures correlation. And you can see blood pressures greater than 160 were significantly associated with symptomatic ICH. They were significantly associated with cerebral edema leading to hemicraniectomies. They were significantly associated with a poor outcome. And again, we see a U-shaped curve where extremes of blood pressure were associated with increased mortality in these patients. So knowing that we don't have enough evidence and enough guidance on what to do with these patients who undergo intra-arterial therapy with recanalization, is there a role for individualized blood pressure targets in these patients? And so this study was published in October 2019, where they looked at autoregulation indices, and they used a non-invasive method to estimate the optimum autoregulation index for patients. And you can see in this graph, you have the yellow curve, which represents the autoregulation curve. And they plotted the autoregulation index against the map. And as you can see, the gray bar here, it shows the lower and upper limits, or the outer limits of the optimal autoregulation index. This is the optimal autoregulation index, and anything that's outside of this is outside of the optimal autoregulation index. And they showed that when patients spent more time outside of the optimal autoregulation index, which is that the blood pressures were fluctuating too much outside of their optimal range, they were more likely to have worse outcomes. As you can see here, as the time goes high, they're having worse outcomes, as well as they had more likelihood of symptomatic ICH if they spent more time outside of the outer limits of optimal autoregulation index. So practically speaking, at this time, our guidelines say that if a patient has received IV thrombolysis, the blood pressure should be maintained less than 180/105 for 24 hours. If the patient has received intra-arterial therapy with near complete or complete recanalization, systolic blood pressure should be maintained less than 140/160, or 140 or 160. Again, in these patients, better to set a lower goal rather than let them run 160s, which typically they end up running higher than that. And in patients who do not get recanalized or have partial recanalization, we follow the same post-TPA guidelines of maintaining systolic blood pressures of less than 180/105. And maybe there's a role for individualized blood pressure targets. Usually these patients are monitored in an ICU setting, and these type of individualized treatments can be probably applied to them. And then as always, hypoperfusion or because of hypotension should be avoided in these patients, because sometimes when the vessel is completely recanalized, it can suddenly drop the blood pressure. And so a volume support should be maintained for these patients as well. So putting it all together, we have our 3 phases: the initial assessment when the patient comes in with the acute ischemic stroke, and we have to decide whether they are a candidate for IV TPA or not. And then depending on that, we use our blood pressure targets. Correction of hypotension in the initial setting is important. In the second phase of revascularization, during the procedure, we avoid extremes of blood pressure. We avoid drops of blood pressure below 140 so that we can maintain cerebral perfusion, but we also do not want the blood pressure to be over 180 because these patients we're following the post-TPA protocol for them. And then post-intervention, depending on the reperfusion status, blood pressure goals differ, and you avoid hypotension after reperfusion in these patients. And then I briefly wanted to talk about blood pressure management in the post-stroke period. As we know, when our patients are admitted with an acute stroke, whether they receive any type of intervention or not, we do discontinue their blood pressure medications to allow for permissive hypertension. And this abrupt discontinuation will lead to rebound hypertension and then consequently an increase in cardiovascular events. So it is reasonable to start lowering the blood pressure after 48 hours to the individual's baseline level, and then gradually aiming for normal tension. This has been shown to improve long-term outcomes. Of course, we have to keep in mind special circumstances such as ongoing cerebral ischemia or neurological fluctuations if the patient has a large vessel occlusion that is not recanalized, or carotid disease, if they have raised ICP or cerebral edema, preeclampsia, etc. These patients will need individualized management. So we when looking at what our blood pressure therapeutic targets are in the chronic phase after a stroke, we know from the PROGRESS trial that long-term treatment of blood pressure and normalizing blood pressure does reduce risk of recurrent stroke. Also from the SPS3 trial, we know that lowering blood pressure less than 130 will reduce the risk of hemorrhagic stroke. So this study looked at, this is a RESPECT study, which compared intensive blood pressure management versus standard blood pressure management after acute ischemic stroke. Standard blood pressure management was aiming blood pressure less than 140/90 versus intensive blood pressure treatment was blood pressure goes less than 120/80. And they were able to show that there was a significantly decreased risk of strokes of all types in the intensive treatment group. I think the major benefit was from reduction of hemorrhagic strokes. They didn't really find any difference in the occurrence of ischemic strokes and any change in mortality or any mortality benefit. However, in a meta-analysis that they performed, they did see that all of the studies favor treatment, intensive treatment. So there might be a role for intensive blood pressure management with goals less than 130/80 in patients who have had a previous stroke. And of course, we have to keep in mind special circumstances, like we mentioned, with patients who have carotid disease versus intracranial atherosclerosis. So we know from all of the chronic blood pressure treatment data that blood pressure lowering has a consistent effect even if a patient does not have a previous history of hypertension. Currently, the American Heart Association recommends initiating or resuming blood pressure medication in any patient who has a history of a stroke, and if they have consistently elevated blood pressures over 140/90. And as we just saw, there might be a role for more aggressive or intensive blood pressure lowering of less than 130/80. And some of this data suggests that this might be beneficial for patients with lacunar strokes rather than large vessel strokes. From stroke data, from the stroke literature, the strongest data is for using diuretics or a combination of diuretics and ACE inhibitors for stroke prevention. However, keeping in mind the other comorbidities of the patient, we should approach an individualized therapy. And treatment should be started prior to patient's discharge from the hospital. So in summary, just bringing everything together, as we saw, blood pressure management in the setting of an acute stroke is a very dynamic process, and it changes depending on the autoregulation status of the patient, their clinical presentation. Extremes of blood pressure should be avoided. We know the U-shaped curve. Therapeutic targets depending on the reperfusion status. To reiterate, if a patient is not eligible for reperfusion, you maintain it less than 220/110. If it's greater than these targets, you gradually decrease it by 10 to 15% in the first 24 hours. If they are eligible for IV thrombolysis or intraarterial therapy, you lower it to less than 185/110. Post-IV thrombolysis or post-intraarterial therapy with TICI 0 to 2A, blood pressure goes are less than 180/105. During recanalization procedures, systolic blood pressure goals should be 140/180. And post-intraarterial therapy with a near complete or complete recanalization, systolic blood pressure goals should be less than 140/160. In the chronic phase, it is reasonable to initiate blood pressure medications within 7 days after a stroke, and then aim for normotension in the long term. And secondary prevention goals are usually less than 140/190, possibly more intensive goals for patients who have had lacunar strokes or hemorrhagic strokes. Thank you. That's all I have.
Hello. Sagar? Is he there?
Yeah.
No.
Hello.
Yeah, carry on.
Thank you so much, Dr. Abasha, for a wonderful insight into blood pressure management in stroke. Dr. Dilip Yavagal, he doesn't need any introduction. He's MD and FSVIN, and is the Director of Interventional Neurology and Co-Director of Neuroendovascular Surgery at the University of Miami and Jackson Memorial Hospitals, and Clinical Professor of Neurology and Neurosurgery at the University of Miami of Medicine. Dr. Yavagal is the founder and global chair of the Global Mission Thrombectomy 2020 Plus, that is MT 2020 Plus campaign to accelerate access to stroke thrombectomy globally and reducing regional disparities in thrombectomy capacity. Dr. International thought leader in endovascular therapy for ischemic and hemorrhagic stroke, as well as a pioneer in the translation of intra-arterial delivery of cell therapy for stroke. He is a president of the Society for Vascular and Interventional Neurology. I keep on bothering him a lot of times for my stroke patients and keep on taking his advice. He will be discussing about future therapies in stroke intervention. Over to you, Dr. Yavagal. Thank you so much.
Thank you so much, Sagar. That was a very kind introduction. I'm just going to get my screen up. A very good evening to everyone in India. It's always such a privilege and pleasure to share the advances in our field with all of you in Mumbai and in India. And today, Dr. Shah and Sagar have asked me to speak about the current stroke interventions and future that we see in this field. So what I wanted to do is really review the data that we have really come to know well with the thrombectomy trials, but in a quick summary fashion, and then talk about the future that we see here. As Sagar mentioned, I'm at the University of Miami in Miami, Florida, and these are my disclosures. I do consult for companies who make stroke devices. I'm on steering committees, but I don't have any royalties or patents on these devices. As I said, we will talk about the early intervention window and the evidence for the early intervention window, and then also the evidence and guidelines for the late window as well as wake-up strokes, and then the exciting advances, including my own focus of research of intra-arterial cell therapy is what I'm going to cover. So starting off with what's now well accepted, well established, and the early window for stroke thrombectomy is really something that all of us have now seen with great outcomes. But here is a early patient of mine from 2013, and I apologize for the misformatting. This is a 63-year-old woman who had AFib, but her community discontinued due to gynecological bleeding, and she came with a sudden onset of left-sided weakness and IHSs of 8. And what you can see, and I'm going to blow up the picture here, is that if you look closely, the aspects in the scoring will tell you that the gray-white junction where my arrow is in the left frontal lobe is blurred as compared to the nice gray-white differentiation here. So -1 here. And then if you come close to the insula, you see how the insula is very nicely defined, whereas the insula is blurred here. So -2. So aspects of 8, and I don't have all the slices, but she was aspects of 8. We also do what are MIP images of the plain CT scans. So this is not a CTA, but these MIP images are very useful because you can actually see the clot in the M1, M2 junction here in this case. And this is a automated function that most modern CT scanners have. And this actually allowed us to skip the CTA and take her straight to angio. So anything that we can do to save even minutes, we try to do. But as Dr. Chaporia and others have said, the routine protocol is to do a CT-CTA. But in this case, we saw the right M1, M2 hyperdense sign that correlated with her syndrome. We took her right away, and you can see how well the plain CT MIP images correlate with where the occlusion is. I'm doing a right ICA angiogram, and for the trainees, this is a AP view of the right internal carotid artery filling, Petrus ICA, cavernous ICA, and then the supraclinoid ICA right here. The cavernous ICA is the entire siphon, and then the supraclinoid ICA is all open, but the ACA fills, whereas the MCA is occluded. There's a cutoff sign here. Just where the clot was seen on the CT, on the lateral, you can see all the MCA branches are missing. This is the ACA that's still filling and collateralizing. We took a microcatheter from the groin all the way up through the guide system into the MCA, and then the occluded MCA and beyond. And I think I'm going to skip this, but suffices to say that we got the catheter beyond the clot, and then deployed a stent retriever and pulled the clot with the stent retriever, and got a reperfusion that I'll show in a second. What I wanted to do, this is the clot that was pulled out. What I wanted to do is also show you a picture from a different case where we are now, almost in all cases, using a combination of the aspiration catheter that you can see an outline here. And let's see if I can show on this scan. This is the outline of the aspiration catheter that is that is just behind the stent retriever. You can see the stent tines here. I think you can appreciate that in both pictures. And I'm sorry, there's I think something that the patient had on the skull. But the combination of aspiration and a stent retriever is often called Salumbra, or a combined stent retriever aspiration technique. And this has now become the first line for in our center and in most centers in the US and Europe to really synergize the mechanism of actions of both. In this patient, we got a nice reperfusion just with the stent retriever. You can see all the MCA branches are now filling. And this was a 2013 case where we went from a last known well from 1445 last known well. Patient was brought by EMS within about half an hour of her calling. So that was thankfully a quick call by the family. The EMS here does arrive within about 10 minutes or less, and then they make an assessment and bring the patient in another 15 minutes. The CT was done within the hour. Groin puncture was done within the hour of the CT. And then from the groin puncture to the recanalization of 52 minutes. This was a first pass recanalization. And this has come down to about half or less than half now since 2013. You can see the follow-up scan. The MCA is nicely open 48 hours later. And just where we saw the aspects, the blurring of the frontal lobe, and then the blurring of the insula and the temporal tip, I should have pointed that out. Those were the only infarcted areas. The rest of the MCA was salvaged. She had a great outcome. The NIHS decreased from 8 to 1, and she was discharged home at 4 days. So this used to be a one in so many patients, 1 in 8, 1 in 9 patients. And the question in the early 2010s was, is this really going to be the case in majority of the patients as compared to doing nothing? And thankfully, not only did 6 trials, and I only have 5 trials here, randomized trials show benefit, but the benefit was just overwhelming. These red bars show how high the efficacy of the treatment is as compared to placebo. And if you look at the data here, MR Clean was the first trial, and the number needed to treat is as low as 3.2 in Extend IA, which actually was the smallest number. So you could argue that the trial was too small and was too selective, and that's why the number needed to treat was so low. But the number needed to treat was also close to, was also 4 in ESCAPE and SWIFT Prime, which were not as selective and were much larger trials. So we have a consensus that the number needed to treat in early window is right around 3 or possibly below 3 if you manage to do a groin puncture to recanalization within 30 minutes in anterior circulation. So I should point out that this symptomatic hemorrhage rate was not significantly different as compared to medical therapy, and was as low as 1% in SWIFT Prime. We were actually a center in SWIFT Prime, and I was on the steering committee of SWIFT Prime, and it's a very proud result that really the treatment was terrifically safe for the amount of devastation the LVO stroke can cause. And you can see the absolute differences here. Extend-IA, 71% of the patients were independent at 3 months as compared to only 40% with medical therapy, and so on and so forth. So we knew in 2015 that it works, mechanical thrombectomy works beyond doubt, and this became the standard of care right away. The number needed to treat is probably one of the lowest in all of medicine, which is something that we as in the neuro and neurointerventional field should be really proud of. This, when you compare it with IVTPA, is less than half of the IVTPA number needed to treat, and for STEMI, the number needed to treat is quite high. This is IV thrombolysis, but even with PCI, the number needed to treat is close to 8 or 9, I believe. So this very powerful treatment is turning out to be applicable across the board. If you look here, the early patients, the late patients, those who got TPA, those who did not get TPA, all subgroups had a clear benefit. So this is again, this is from MR Clean subgroup analysis. And what you see here is the age is really one of the biggest questions, or was one of the biggest questions before the trials were done. Age less than 80, clear benefit. Age more than 80, wide confidence interval, but the point estimate is actually even more than age less than 80. So clear benefit in very old patients, and this is a clear-cut result because again, 80-year-olds were compared to 80-year-olds, and certainly they do poorly as compared to 60-year-olds, but that patient's chance of having an independent outcome is much higher with thrombectomy, regardless of their age. So we wrote this within about 3 months of the trials being published, thanks to the prowess of Dr. Powers, but I was fortunate and privileged to be part of this guideline that established that mechanical thrombectomy for less than 6 hours symptom onset was the new standard of care. What also became clear from the meta-analyses of these data is that this outcome, this benefit is highly time sensitive in the first 6 hours. Again, CT, CTA, and thrombectomy. No selection was advised by the guidelines, and this is a analysis of the 6 trials, and majority of them were not selected except for by perfusion imaging, except for Extend-IA. And what you see here is that this slope of a odds ratio on the y-axis and time from symptom onset is a constant downward slope that the outcomes keep going down with time in the 7.3 hours from symptom onset. And so when you look at that with more detail, the chance of a functional outcome is 64% at 3 hours versus 46% at 8 hours. And so this is a very clear difference, close to 20% difference just within about 5 hours in the early window. And that translates into every 1,000 patients treated, which is now happening in a given city. Every 15 minutes faster door-to-door perfusion, 39 patients would be less disabled. And so I would think that Mumbai will reach 1,000 patients per year very soon, and 39 of them would be less disabled if they had a thrombectomy done 15 minutes earlier, and 25 more would be fully independent. with a 15-minute faster door to reperfusion time. So any minute or two that you can save is shown to be clearly beneficial, and this is especially challenging in India, and I know that all of you are making tremendous efforts to cut down this time. So this is a 2018 guidelines. Level of evidence is A, and the strength of the guideline is 1, the highest guideline recommendation. Patients should receive mechanical thrombectomy with stent retriever, and this is because most of the patients were treated with stent retriever in these trials, as long as their pre-MRS score is 0 to 1. So they are essentially independent. They are independent and with no deficits, and their causative occlusion is in the anterior circulation, and their age is more than 18 years. There's no upper age limit. The aspects is 6 or more, and the treatment can be initiated within 6 hours of symptom onset. All the benefits of mechanical thrombectomy are uncertain for M2, M3. They should still be considered when they can be started within 6 hours. 2B, lower level of recommendation, lower level of benefit, BR. These are all retrospective data up till now, and some prospective data from these studies which excluded these occlusions. And then for posterior circulation, all the benefits are uncertain. The use of thrombectomy may be reasonable. So 2B, and this is expert opinion. When you look at the later window, which includes wake-up strokes, the trials thankfully were underway as the early window trials were being done. And all of us know that this window was really in question whether the benefit will pan out, and even if it panned out, whether it would be as beneficial. This is a 62-year-old lady who woke up after being seen after going to bed at 10 p.m. the night before, and NHSS was 20. You can see this is a MRI. Again, we do CT perfusion as a routine, but in this case, we had done an MRI. You can see there's a diffusion infarct that's fairly small for the NIHSS score, and there is an ICA occlusion on the MRA. And the question is, how is this patient, in where does this patient stand in this variable infarct progression that patients have? Dr. Chaporia showed a great example of the collaterals that make a difference, and you can see that some patients, they infarct right away, and within at 4 hours, they have a 180 cc infarct. There are several who are slower, and then there are some that go, as we've seen in some recent publications, beyond 24 hours even, where their progression is very, very slow, and they'll stay below 30 cc infarct. And so this is the basis of the late window, is if we can select these patients, and the patient like this is a good one because there is a clinical diffusion mismatch, and this patient would be a candidate for the diffuse study. In the DAWN study that we were part of, the CT perfusion or MRI diffusion clinical mismatch was the selection that was used. And I'm not going to go into the criteria just in the interest of time. We've discussed them before. The outcome was significantly beneficial with thrombectomy. 48.6% of patients had an independent outcome as compared to only 13% with medical therapy. So not only was the benefit there, but it was higher even than in the early window, because when you do nothing for these patients, they do very poorly. Certainly the selection with perfusion also contributes to this higher number. And you can see the confidence intervals were quite tight, and the odds ratio was clearly double the chance of benefit. The symptomatic intracranial hemorrhage rate was again not significantly different, 6% versus 3% in the medical treatment group, and diffuse finished right after and showed the same outcome result. Here, MRI was the modality that was used with perfusion diffusion imaging, and the trial was slightly different, that it was only up to 16 hours rather than 24 hours. The DWI volume had to be less than 25, or the mismatch core had to be more than 15. And the core volume that was allowed, actually, if you had the mismatch, was quite high, up to 70 cc's. And the average core volume was much lower in the patients that were enrolled. And this, again, showed a 40% benefit with thrombectomy as compared to only 15% independent outcome in medical therapy. Across the subgroups, and I'm sorry, this is a little, this is cut off here. That's my error. But age and almost every subgroup, there was clear benefit. So based on these two studies, the guidelines, the 2018 guidelines, say 1A recommendation for in patients with AIS from 6 to 16 hours of last known normal who have a large vessel occlusion, the anterior circulation, and they meet the Dawn or diffuse eligibility criteria, mechanical thrombectomy is recommended. Again, because both trials had the 16-hour patients and only one trial had the 24, the guideline is for, the 1A guideline is for 16, and then the 2A BR recommendation is for 16 to 24 hours, because there was only one trial that showed this window to be beneficial. But I think this is followed fairly universally, at least in the US that I know of. We go up to 24 hours and sometimes even beyond. CT, MR are both acceptable, 1A, because trials use both. And this is another Dawn case from our center, or Dawn type case, or a late case, I should say. This is not from the trial. This is a 75-year-old right-handed gentleman who had vascular risk factors, cabbage ×3, who presented with a right MCA syndrome at 14 hours. So last seen well 14 hours ago. And NHS was 16. They were independent at baseline. The CTA showed a M1 occlusion. And what you can see here is the CBF is almost non-existent. And I say almost because there is always an error margin, but we don't see any core. And CBF is what denotes the core, which is less than 10 ml of flow. And the penumbral tissue is almost 77 ml. And the mismatch is very large. This patient was taken, was found to have the M1 occlusion on angio that was seen on CTA, recanalized with the combined treatment, which we often call Solumbra. And these are the devices used, Solitaire and the A68. We got a first pass Tiki 3 with a very good outcome, functional outcome in the patient. So I'm going to switch now to a little bit of the future, and one of the biggest areas that are that is unresolved is distal occlusion and low NIHSS. So this is a 79-year-old lady who had a history of hypertension, atrial fibrillation. She went to an outside hospital with slurred speech, facial droop, and a right arm weakness, and NIHSS was 6. Stroke onset was 8 a.m. Arrival was 10 a.m., so came pretty fast. Recent trauma to the head, so IVTPA was contraindicated. Apixaban was stopped a week ago, and that contributed to her cardioembolic stroke, but she couldn't get TPA. And what we saw was that the M1 was open, and I'm sorry, the scan, it does not have the correct windowing, but you can see that there is a cutoff in the M2. The M1 was open on the left side. So when the patient arrived, her NIHSS actually went down to 2 in our center. And what we saw was that we had to really decide whether we are going to go after this distal occlusion with a low NIHSS. We did a perfusion scan, and we saw that there was a pretty large territory of the operculum insula on the left side that was at risk. This could ultimately lead to aphasia. So we, as I said, she arrived to us at 4 hours on symptom onset. Exam had improved. And the question that I already answered was that we did do additional imaging before taking her to angio to support our hypothesis. And what you can see in angio is that there is a cutoff right at this, and this is the M1 right here. M2, this is the posterior M2, and you can see the branch stops here. We put a stent retriever in that branch, and you can see as soon as we put the stent retriever, we got a nice recanalization. You can see this vessel was not there before. You had this curve like that, inverted hockey stick. But apart from that, there is an overlying vessel that is now open, with the stent retriever. That's one of the advantages of stent retrievers. Even before you pull the clot out, because the clot is pushed to the side by the stent, you get an immediate reperfusion even as you wait to pull the clot. And once we did the reperfusion, we had a nice reperfusion in the occluded branch. And you can see before run and after run. And this is a later run showing that the occluded branch is now filling, and this patient had a salvage of that tissue at risk with a complete resolution of her NIHSS. Now, this is the thing that prompts you to really be aggressive with especially left hemisphere low NIHSS and distal occlusions. But this is a 66-year-old gentleman who had a previous pontine stroke, woke up with a leg weakness, and leg weakness is disabling. He was out of the TPA window. What do you do for a patient like this? We saw that the aspects was good. The ACA was occluded on CTA in the A3 branch. So we decided to really go after it. And you can see the branch here that should be filling is occluded. We went after it with the microcatheter. You can see we identified the occlusion clearly. We passed a wire beyond it, used a mini stent retriever that is of a smaller size, and unfortunately got a hemorrhage. So this is unsettled, and it's really something that we discuss many times with the family before we do, so as we do not know for sure whether it's going to benefit or not. So a leg weakness now has become a full-fledged abulia, and then the patient actually ultimately died. So this is still quite unsettled in my own practice. I am fairly aggressive, especially with aphasia and then in the posterior circulation with hemianopsia. Overall, our devices are getting better and better. And our techniques are getting better and better. It's very critical, I think, to use a supporting, what we call distal access catheter or intermediate catheter. So you're not completely pulling just with a stent retriever on the distal artery, because it's not as well supported as the M1 segment or the basilar. With that technique, I believe that our rates of hemorrhage are on the reasonable side, less than 5%. And we can get a good outcome. But again, this is anecdotal, and retrospective series are supportive, but the trials are ongoing. I'm going to quickly pivot to whether we should give IVTPA or not before thrombectomy. And this is the hottest area, as all of you know, in thrombectomy right now. We had the direct MT study come out last year from China, and it showed non-inferiority of direct thrombectomy versus MT plus IVTPA. The main thing was that the confidence intervals, even in the non-inferiority, were very, very narrow. But now we have the SKIP trial that it did not show a clear, that did not reach non-inferiority, but the numbers were very common. So if you look at MT only, and skip the percentage of patients who had a good outcome or 59 versus MT plus IVTPA 57. So even though the non-inferiority was not reached by MT, numerically they were very similar. And then DEVIT, which also was just published, actually did reach non-inferiority. So you can see MRS 0 to 2 with MT was 54%, sorry. And the MRS 0 to 2 with IVTPA was 46. And this was a clear non-inferiority that was reached. So yes, no, and yes. So we have 3 studies. This is often questioned because of a very low confidence interval, and it's a statistical thing that I can't get into in the interest of time. But we now have a real body of evidence suggesting that a direct thrombectomy may be as good as compared to TPA plus thrombectomy in anterior circulation. But the biggest caveat is all these patients directly came to the thrombectomy center. They were not transfers. And that's where the biggest unanswered question is. And this happens in the US, in close to 30% of the patients now, with a lot of bypass protocols, but they're still going to transfer centers. I'm sorry, they're still being transferred from a primary stroke center to a comprehensive stroke center. In that case, there is no reason to not give IV TPA. Again, these data are still being taken into consideration. The guidelines haven't changed. So especially if a patient is being transferred or has a delay between IVT and thrombectomy, they should get IV TPA. But I think we may be heading towards a new recommendation where if a patient directly comes to a thrombectomy center and they have a M1, M2 occlusion, ICA, they may actually skip thrombectomy. And again, this is all just alteplase, as Dr. Echevarria had talked about tenecteplase. We don't know what the results with tenecteplase and thrombectomy may be. And there are a lot of believers that tenecteplase plus thrombectomy actually may be superior to just thrombectomy. So it's unsettled overall. And so in our center, we are very much still in the 2018 onwards mode. 0 to 5 hours, we give IV TPA, do CT aspects and CTA, and take the patient to thrombectomy if they're eligible. After 4.5 hours, up to 6 hours, we do CT aspects, CTA, and thrombectomy. And if the non-contrast CT aspects, the MIP images show hyperdense MCA, we can even skip CTA. Wake-up strokes, we do the perfusion imaging. 99% of our patients get CT, CTP. Some patients get DWI and MRA and go to thrombectomy. I'll take one slide to talk about the thrombectomy gap. And I know this is really just a sharing of the fact that even though thrombectomy is so highly beneficial and can save decades of being disabled and in wheelchair bound or bed bound, even in the US, the estimates in 2016, I'll skip right to 2016 here, the number of LVOs in the US are estimated to be 180K, and this is a very conservative estimate with only ICA and M1 occlusions that may be as high as 200 to 250 if you start including M2s and posterior circulation. In 2016, the number of thrombectomies that were done in the US were under 20,000. So the gap is just massive. Only 1/10 of the patients, even in the US, got thrombectomy. And worldwide, this is a chasm, a valley of a gap where if you consider that only 10% of all strokes are LVOs as a very conservative estimate, there's about 1.7 or somewhere in the range of 1.3 to 1.7 million LVOs globally, and the number of thrombectomies in 2016 were less than 100,000. And this has reached 200,000 as a projection in 2020, but we are still very far away in terms of a gap. The cost effectiveness of TPA has been shown in multiple studies now in the high income countries, but Brazil just finished a cost effectiveness evaluation of Resilient, and even in Brazil, a middle income country, thrombectomy is highly cost effective. And I think a lot of you know that data. So based on that, there is a real global need to increase, but actually accelerate access to thrombectomy. And I think I've spoken to several of you about the campaign that I'm very fortunate to lead called Mission Thrombectomy, now called 2020 Plus, where we are using public health interventions and communicating with governments to double access to thrombectomy every 2 years. I'm going to quickly cover the evolution of stent retrievers. This is the future. I think I'm doing okay on time, but Sagar, please let me know if I'm running over too much. I just have about 10 more slides to go. So first generation retrievers were Mercy retriever. They were simple, a single coiled wire or a single alligator. That changed massively with the finding, just serendipitous finding that a stent configuration actually grabs the clot a lot better. This is the solitaire, the Trevo, and then preset is slightly different design. And then we don't have aperia, but that's these are all tubular structures that were now used as stent retrievers. And I'm not covering aspiration catheters because they are really only changing in their navigability and their bore size, but in terms of the actual device, the aspiration catheters haven't changed. But certainly they are way more effective now than before. And Phenox is another tubular stent that was released, but this has now changed to the third generation to what are called segmented stent retrievers. And so segmented stent retrievers have multiple cages. This is the Embo trap. There is a microvention catheter, stent retriever, and a 3D stent retriever that have a cage. And the idea is that these cages will have a better first pass rate by holding on to multiple parts of the clot with their cages. And then the fourth generation stent retrievers are what are called active expansion stent retrievers. There is Neurovasc, there is a Tiger Retriever that can be changed. Their size can be changed. Their size can be changed in the vessel using and even Vesalio. The size can be changed using a control at the proximal end, where the size goes up and down. And you can see a thin wire here. So that's what controls the stent retriever size. And so you can think about it as massaging the clot and holding on to it better with a stent retriever like this. And you can also change the size depending on the vessel you're in. And really now we are gaining some control on some active control on the stent retriever with these devices. So this technology is continuing to evolve in a very exciting fashion. You can see this table just as to how many stent retrievers are out there, and more are on the way, because this is there's clearly a big need, both for the number of patients who need this and also for the iteration that has to go on. I'll just take 2 minutes on the field of intraarterial cell therapy in acute stroke, and this is my area of research for the last 14 years in the lab. When you look at giving cells intraarterially, and these are bone marrow mesenchymal stem cells, intraarterial delivery leads to a much higher concentration and a much more even distribution of cells. This is the rat brain. This is a study published from Dr. Chop's lab in Detroit. But intracisternal and IV therapy takes about 3 days to get cells there, and they are in a very limited distribution. So targeting the injured ischemic area is done very well by intraarterial therapy. The big downside is that these cells, especially the bone marrow mesenchymal stem cells that are on the shelf, allogenic cells from healthy donors that are ready to go, they can be very large in size. And you can see they can occupy the entire lumen here. This is data from my lab. What we know, though, is that when we lower the dose, the cells, even though they occlude these capillaries, they also diapedese out. They have this amazing biology that all our WBCs have, but these stem cells in our bodies, and when given from outside, have is a CXCR4 receptor that homes towards STF1's chemokine that's secreted in a ischemic brain. And these cells, they diapedese, homing towards the STF1. And we had in one of our rat brains this cell that's half in and half out. So when we give cells intraarterially, they go towards the ischemic brain. And in this study that we published, the control animals had a significantly larger infarct at 30 days as compared to mesenchymal stem cell treated animals that were given intraarterial mesenchymal stem cells at a dose of 100,000 at 24 hours. This was the area that was salvaged by these cells at 30 days. And this is a large animal model that we've studied in our laboratory canine model, where the intraarterial delivery in a dose escalating fashion showed safety up to 40 million cells. And you can see the infarct size is dramatically reduced at 28 days, and no new infarcts are seen. This is a control animal. You can see there is a shrinkage, but this is not as dramatic as what we see in the treated animals. So we are finishing our statistical analysis on this and hopefully publishing this soon. I co-led a study on intraarterial delivery, a phase 2 study of 48 patients called Recover Stroke. And this showed safety. I'm rushing a little bit. We gave the cells from the patient's own bone marrow at 14 days after 48 hours of processing. So that's different from the allogenic delivery. We gave them a supraclinic ICA intraarterially, and there was clear safety. The cells did not cause neurologic worsening. There wasn't any increased risk of seizures. There was increased DVT in the treated cells. These are ALDH bright cells from the patient's own bone marrow. In this study of 48 patients, there was no clear change in efficacy. Again, a very small study that did not have the power to look for efficacy, but did show safety. So there's a long-term safety. The patients were followed to one year, and the treatment was safe. There was no difference in the efficacy outcomes. But based on our animal data and the safety of Recover Stroke, we have proposed a stem stroke phase 2b trial of anywhere from 150 to 200 patients, where we will be giving cells at between 24 to 36 hours intraarterially, and really see if this results in better outcomes, especially in patients who either are not eligible for thrombectomy or after thrombectomy do not improve within the first 12 hours by more than 8 points. So these are the patients who will be selected and treated with cell therapy in the study once we have the funding. So in summary, mechanical thrombectomy for LVO stroke is among the most powerful and beneficial treatments in all of medicine. Outcomes from thrombectomy are extremely time sensitive, especially in the 6 hours window, and the impact of the delay is unlike any emergency we are used to. Every 15 minutes, as you know, in the casualty or ER goes by in a flash. Contribution of patient selection strategies to efficacy and safety has to be weighed against delay in minutes. So any extra test you want has to be weighed against the patient's chance of actually having a poorer outcome. And only if it's worth it, we need to add that time. Selection with CT-CTA is a class 1 recommendation in the early window, and CT or MR is recommended, class 1 recommended in the late window. Substantial reperfusion, TK2B, should be the goal of all thrombectomy procedures. So more than 50% reperfusion is our goal. Anything less, the chances of a good outcome are very low. And so all of us neurointerventionalists really have to know our techniques that get us this more than 50% reperfusion. And this is now a clear guideline recommendation. So if you don't achieve this, you really have to have an explanation as to why. And then the future substantially advances in acute stroke interventions are likely to come from advances in stroke systems of care. And so I've not actually covered this, but I don't want to say the others without saying what is the most high impact is as our stroke systems of care bring patients who from the field in a very fast manner, including mobile stroke units and telemedicine that I have not covered in this talk, is one of the biggest advances I'm excited about. Newer generation thrombectomy devices are going to increase the rates of success and reperfusion in just one pass. And then cell therapy and biologics are really very promising and can add tremendously to this advance that has been made. And just a plug again for MT 2020 Plus, where we are really joining forces throughout the globe with experts like you to devise public health interventions to increase access to thrombectomy. Thank you so much.
Thank you, Professor Dilip, for an excellent review of the present and future of what is happening in mechanical thrombectomy and stroke intervention. We really enjoyed your talk, and I request you to continue to remain so that Dr. Nishant is going to present some cases which we in the same field. So I'll be inviting Dr. Nishant Aditya to join, and basically this will be more of an interactive session with case presentation, so it will interest all the clinicians. Now, Dr. Nishant Aditya is a consultant neurointerventionist and neuroradiologist in the Department of Neurosciences at Research HN Reliance Foundation Hospital and Research Center. He graduated from University of Gujarat and then he completed his radio diagnosis. He's been consultant for last 10 years and has performed more than 100 intracranial aneurysm coiling, arterial recanalizations for ischemic stroke, including mechanical thrombolysis using penumbra, solitaire, and revive devices. I think he's also had vast experience also in managing dural level fistulas. I think he is the backbone of our stroke unit at Reliance Hospital and is available round the clock, anytime, 3 a.m., 4 a.m. is there to support us. So I looking forward to Nissan, who is going to present some of the cases of intervention which we have done in this hospital. Nishan, carry on.
Thank you, sir. Can you see my screen?
Yeah.
Thank you, sir, for a nice introduction. And I will go directly to case presentation and with a nice introduction of IVTP with Dr. Chapuria, Dr. Dilip Ayagal in the recent advances in mechanical thrombectomy. So this is 66-year lady presented with right facial brachial weakness since 4 a.m. She came to our hospital at 6 a.m. and at that time virtually recovered with minimal residual nominal aphasia. So NHS was 4. She was on single intubated for the past stroke, and this was the MRI. Very small deep white matter ischemia on the left side with small chiral early ischemia on the left side. And this was the neck angiogram. You can see left side IC is occluded in the neck. This is the right side, and this left side occluded. And a competent circular villus. You can see through ACOM MCS filling reasonably well. In 2016, she presented with the left facial brachial weakness with the opposite side, right hemisphere stroke. At that time, if you notice, the left carotid artery virtually normal. Small plaque at the right bifurcation and normal circular villus. So just to compare 16 and 18, you can see here the IC is presented 2016 stroke and now it is occluded. So to the panelists, should we recanalize now given the circular villus is competent or not?
Yeah, I would certainly. I'm sorry. I don't know if this is an open question that we can circulate, right?
Yeah.
Among us.
Yes. Yes.
So I would certainly. My first line of treatment would be conservative, where we maintain the patient's blood pressure and see how she does. Given that there is really such a good cross flow, and the risk of recanalizing that occluded ICA, which is probably a ICA terminus occlusion, may not really justify the small stroke that she's having. Most nominal aphasias almost recover completely. I'd love to hear what Sagar or anyone else has to say.
So I will definitely intervene in this patient, sir, because we know that these patients may worsen and they may throw more emboli. She definitely has embolic stroke in left MCL distribution. So I think this is the right time. Unfortunately, we don't have a perfusion scan to see whether this collateral is adequate or not. We can see that the MCA is filling by collaterals, but we really don't know whether that collateral is sufficient or not. Her NIHS is not. Was there any clinical mismatch between the NIHS and the small tiny infarcts we are seeing on the scan? That will probably help me to take a decision.
Yeah, no mismatch. Yeah.
Okay, but
So,
I mean,
Yeah,
But I would like
just
to intervene. Looking at the previous scan in 2016, the vessel looks clean. Probably the lesion is at the IC origin, and I will definitely intervene so in this patient.
so you're making two really great points. What is the risk of worsening? And secondly, where is the occlusion? Is it at the cervical ICA, or is it a clot at the terminal ICA? So to both, I would say that in a patient who has a cross flow across the ACOM with the M1 and its distal branches completely filling, with the opposite carotid that's open, the rates of worsening are actually, just without more embolization that you are alluding to, are actually pretty low. But the MRA does not really tell us whether the occlusion is cervical or higher. I think if you observe this patient in the ICU and decide to go in only if she worsens, is something that's not an unreasonable strategy. The main decision is with an NHS of 2. Would you want to give her the risk of a NHS worsening that's in the range of about, I would say, 5% or so. So yeah, no, I think that's definitely something that's unsettled with randomized trials just yet. But trials like Endolo and others will give us an answer.
Yeah. So thank you, Dr. Yavagal. This is what we thought at that time, that circular Willis is competent, there's a reasonable ACOM, and almost bilaterally with intensity with the TOF angio, it looks symmetrical. Same night at 3 a.m., she became unresponsive and NIH dropped from 4 to 18.
Sure.
And this is the MRA shown a new infarcted area in the posterior gyrus, posterior sylvian gyrus, and negative flare, which I expected very early MR. So just to compare, 6 a.m. and 3 a.m. is new infarct, that only infarct, and there is a temporal evolution of the small infarct. And now we can see there is no MC opacification.
Right.
So certainly the thrombus has progressed from the T occlusion or from the neck to the top. And this is the bold image. We can see the medullary vein early appearance is the sign of a holohemispheric ischemia, which was not there in the early morning scan. So now what? We should go ahead.
Right. I think that's a fairly obvious answer, and that was what I was alluding to. I will make a comment that studies that have looked at this strategy of ICU observation and going in do show that there is not that great an outcome when you come in after the patient deteriorates. So that's definitely one of the biggest concerns of looking for deterioration. But I would still have done the same thing. So let's see what happened.
I have a couple of queries. What treatment did the patient receive? Was she on heparin, or was she only on dual antiplatelet? What was the strategy to treat the patient? Number one. Second question to Dr. Yavagal: will rapid AI help in such patients to? I mean, this was obviously an embolic stroke. And third is, does an SWI image showed the occlusion site, whether it was in the cervical ICA or whether it was close to T? Was a SWAN image was showing any thrombus? SWI image in the first scan.
So in all stroke where we don't treat because of the NHS, low NHS, or when we conserve the patient, all patient will have permissive hypertension, blood pressure approximately more than 140 all the time, hydration, and low dose of heparin with antiplatelet loading, unless the size of infarct is big. For the site of thrombus on the SW and the MIP images, that mean on the MRI, the source images, it was looking like a cervical occlusion even at that time, because there were no obvious SW large blooming in the intracranial circulation. So those were the things at the back of mind, even we conserved. So this is what we found out. You can see here the occlusion in the neck and no opacification through ACOM, which was obvious in the morning MRI angiography. So to go ahead with that, we first created a passage through angioplasty, very small underinflated angioplasty. And this has created small passage first, then second inflation. And now we have a significant amount of passage in the neck. And this is the intracranial occlusion, which is obviously seen as a M1 now. And single aspiration, large carotid rigidity from the middle cerebral artery, and TK3. So now,
can I ask how quickly? I'm sorry, Nishant, I was just have some curiosity about the systems of care. What time was the thrombectomy done? At 3 a.m. she worsened.
Yeah. So by 4:30 we have recanalized it.
Oh wow, that's great.
Yeah, because we were all these patients when we reserve, we put a very, very high alert. Even the minor deterioration, we are there. So is as sir mentioned, is very good system now we achieve for the neurocritical care, plus the reaction time is very good now.
Awesome. That's awesome.
So to stent or not to stent now?
Sagar, you want to go first? I want to see if
I mean, post balloon angioplasty, I can see a reasonable opening of the vessel. That is number one. Number two, she's already loaded with antiplatelets and heparin. So I have really no hesitation to put a stent and stabilize the plaque. But at the same time, the artery looks reasonably open. I'll wait for half an hour on table. I'll take a check shoot. And if the artery is open, maybe I can postpone putting a stent now. But putting a stent at this time also can be a reasonably good choice because she's already on treatment with antiplatelets and heparin. So either way, yeah. I mean, it's Nishant's call.
Yeah, I would
feasible
put
to
a
me.
stent in. I would put a stent in this case because I think it's very hard to predict reocclusions. There is actually some irregularity you can see at the distal end, and like you said, with the antiplatelets on board, that would be my my approach because I've just seen too many reocclusions, 12 hours later and such.
At that time, I just conserved because after 1 hour it is reasonably open, except little ruffling just at the bifurcation.
Sure.
So I conserved it, and so next day she progressively made a very good recovery, extubated over 4 or 5 days, virtually normal, and at the time of discharge, NHS was 3. And this is the day 2 or day 3 CT scan showing just temporal evolution of the posterior parietal infarct. We salvaged a significant amount of tissue, and on day 7 discharged. 1 month follow-up, asymptomatic, color Doppler continue to show 70% stenosis of left ICI origin, interval carotid Doppler. So I put her for interval stenting at 2.5 months. So here we are back to square one. She occluded the carotid on the left side with again a competent circle of Willis. So to panel, now should you revascularize or conserve?
At this point, it's a chronic occlusion.
I'll conserve for sure this time.
Yeah, I
But
would
was there a
also do the
flow
same.
into the carotid? Was there a flow across the stenosis on the on the
So
left side?
so that is very interesting. If you see, there is some track there, right?
Is it a collateral flow, or it is through the occlusion, or it's a collateral from
No,
the external carotid?
yeah. So this is through the ophthalmic artery backflow.
Then I
This is
think
ophthalmic artery reforming. Yeah.
then I will leave it now. I mean, he is well collateralized. She is well collateralized. I think I will not do it now at this point.
There is some data, mainly retrospective, that if the so if you hold it right there, if the you see how the contrast comes retrograde,
Correct.
and if it
Yeah.
comes retrograde within 5 centimeters of the bifurcation,
Yeah.
there is a good body of data showing that you can have a highly feasible and safe revascularization. So if the patient just is not having any TIAs, I would leave it. But if they are having some symptoms, this is one chronic occlusion where there is reasonable data to revascularize.
Okay. Ditto, with this back of mind, we are having reasonable amount of data for the petrous and this retrograde opacification till the bifurcation. 4 to 5 centimeter, if it is coming, it's very good criteria to revascularize. So that's how I did. So the passage was little tricky because it must be a few weeks. So I kept a very good balloon guide here to just keep the proximal flow, the whole idea to prevent distal emboli, and very gentle flow to check after the balloon inflation, and then is virtually recanalized just after the passage of microcatheter, exchange with it, and then put a distal protection device. And this is the post inflation of the balloon post stenting. And this is final post. If you notice here, you can see a small thrombus stuck at the mouth of distal protection device.
Right.
And this is what it is now. It's recanalized, and this is final. So no distal emboli. In all these cases, I keep a proximal protection along with the distal protection. So we are doubly sure that nothing is thrown into the circulation because these patients are virtually normal and we are doing just a future prevention of stroke. So this time, uneventful hospital stay.
Great job.
Next case. Thank you. 70-year lady presented with left face brachial weakness since 2 hours. Similar episodes 2 days ago also. It was brief. This time it was little longer duration. That's how they came. And NHS 8 this time. And the power approximately 2-3 and lower limb 5/5. Her case, the infarction in the AC area, intercerebral area in the front lobe. And on the top, there is no opacification of very poorly opacified middle cerebral artery and no opacification of the carotid artery. Here also you can see there is no carotid artery on the right side.
Right.
And something is happening to the support to the middle cerebral artery and anterior cerebral artery at the anterior communicating artery complex.
Mm-hmm.
So now, anterior cerebral territory ischemia, middle cerebral territory virtually normal in terms of diffusion defects. What are the options we have now?
Was there a small infarct in the NCA territory as well? A very small tiny infarct.
So
that is, if you can see the diffusion image.
that is the correct. That is the old, the 2 days ago. You can see here.
Yeah.
So that the reason not to the IVTP was not given at that time. Means at this presentation.
Can you go to the MRA? Is there a flow gap in the right M1? If you go to the next slide.
This one?
Or is that just
that is artifact?
Okay. Yeah. No, go ahead, Sagar.
So what is this stroke mechanism? Is it a chronic occlusion at the right ICA, and or it is still the right ICA which is symptomatic? I mean, what do you think? I think it's a right ICA which is symptomatic, right?
Correct. So that was the only two possibilities are there. One is the right side occlusion, or acute on chronic occlusion, and second thing is right middle cerebellar in ACA is filling through ACOM in the long run, and then C3 emboli from the left side to right side. Both possibilities are possible, but common is the common, which is the right ICA occlusion, followed by this kind of symptoms in the ACA territory.
So I want to make a point before you show us what you did. Is I often use these situations where there isn't a clear-cut answer to proceed with the diagnostic angiogram, and as we know from the history, diagnostic angiography was the only neuroimaging available even before CT scans, and we don't use them for diagnostic reasons enough because of the non-invasive imaging. But these are the cases where I will take the patient for a diagnostic angiogram. So we'll start with a diagnostic catheter instead of an intervention. And that, I think, that data helps you tremendously in making a decision whether you want to intervene or not.
Yeah, this is what I did because nothing was clear cut. ACA territory stroke, then opposite side is occluded, and so I did a proper DSA, all 4 vessels, 6 vessels, whatever we did at regular digital subtraction angiography. Yeah, okay. Yes, Dr.
Before we go to, I have a question to Dr. Nasli. So say, for example, this patient undergoes a CT scan and we see an infarct in the ACA territory. I mean, practically that small infarct which she had 2 days back will not be visible on CT. So will you thrombolize this patient or no?
At what was the time of onset, you said?
So she came to hospital within 2 hours.
2 hours. Of course, I will thrombolize.
Yeah.
I mean,
so if you,
it's in the guidelines. I mean, where is the doubt?
So if you see the diffusion, we have a small infarct in the MCL territory which looks subacute.
Never. Which one?
This one.
That was how long ago? 2 months, you said, no?
2 days.
2 days.
2 days. I don't think that would bleed, So what are we worried about? We are worried about symptomatic ICH in an infarcted area. Now, that is very small and it's peripheral. I don't think it would bleed. But I would give IV TPA or IV tenecteplase in this case. And I don't know why you don't want to do a CT angio instead of doing a DSA. If we do a CT angio, maybe we'd see something, instead of doing an invasive procedure. That is my view, because I'm a physician. I'm not an interventionist. Interventionists think differently. But this patient is within 2 hours. NIHS is how much you said? 6, 8? 8. I would give IV therapy, and then take it from there. Maybe if there is a large vessel occlusion, I would think of doing intervention.
So we know, Dr. Chaporia, that there is a large vessel occlusion. Whether it's acute or chronic is what's unclear, right? Because the right ICA is gone.
So many vessels are involved. The ACA, is she diabetic?
Not diagnosed till the admission.
Yeah, but not a known diabetic, you said.
No, not known diabetic.
Yeah, but there are so many vessels. Both the ACAs look diseased. The MCA looks diseased. So I don't know. This picture is not very clear. You say the ICA is blocked.
Right. Correct, sir.
Yeah.
So the only thing I would say, and this is not clear cut, is again the issue of time versus additional tests.
Yes.
The advantage that going directly to a cerebral angiogram is that you skip the CTA, the time taken for that, and you do an invasive test, but you're ready to intervene right away if the detailed information shows poor collaterals from the other side and you know exactly where the occlusion is. That's the advantage of the cerebral angiogram. And the only other thing I'll say is that even though it is invasive, the delay and the devastation that the delay causes, it has to be weighed against that invasiveness. And as cerebral angiography has become more common now in the endovascular era, I think our rates of complications with cerebral angiography are quite low. So that's the
that I would agree. So you would take up. Would you give IV therapy before taking for the DSA?
Yeah, I agree with you, Nasli.
Yeah.
That
So perhaps you can do DSA, but for us, practically, I don't know what the situation is elsewhere, but it would take at least half an hour to mobilize the cath lab for us. So I don't know. Maybe you can do it faster. If you can do it faster, why? Wonderful. Just do it.
The point what I feel, Dr. Nishant, is that say for example, if it is a left A1 small thrombus which is causing the problem in the circulation, which is causing the strokes, there is a good chance that IVTPA may open that. But if it is occlusion at the carotid on the right side, probably IVTPA opening it is extremely low. So I don't know if it is a left A1 which is the culprit artery, the IVTPA probably will definitely help this patient before doing intervention. That's what I feel.
Quite true. So we don't know which is the culprit and whether the carotid is chronically blocked or acutely blocked, and patient is in the window. So definitely I would give IVTP a go and then take it to the next level. I won't leave it there, but take it to the next level. Yes, you can do a DSA if you can do it within 5 minutes or 10 minutes, or else do a CT angio, which can take another 10 minutes. Whichever is suitable in your situation, but I won't leave it at IVTPA. Yes, but I would give it certainly. I would give it certainly.
Sir.
Yeah.
Thank you for input, sir. And this is what I did. So DSA shown a chronic occlusion of right ICA to the origin, and if you notice carefully, there is a suprachoroid formation of ICA through the ophthalmic artery. And look carefully, there is a disease there also. This suggests a very long-standing carotid occlusion. You can see little vasa vasorum is going there up and stopping. It's going nowhere. This story on the right side, which is the symptomatic. This is vertebral artery angiogram showing very good collateral through the PCA. And there is very small PCOM for the right side. And the left side is the real story. You can see here, there's a competent circle of Willis, and you can notice here thrombus at ACOM complex, left AC ACOM complex, which is hampering the flow to MCA and to ACA. So that's why it is so poorly specified that it's not picked up on the TOF MR angiography. So now what are the options with us?
Give IVT.
Was an ASL done? ASL, because I can see that even the left ICA is not feeling well. There is a lot of bare area in the left ICA as well. You can see that there is a bare area in the left ICA also. So it's bilateral ACA and left ACA also is not feeling well. So it's like bilateral ACA
Correct.
and the left and the right MCA.
Correct.
So a lot
because
of
this
say that
thrombus.
this. Yeah.
So
I mean, it has
thrombus.
to be recanalized for sure, whether it's with IVTPA or I mean, this probably IV can also open this small thrombus. That's what I feel. But I mean, you are on table, you have done a DSA, it's easier to open that way by doing a mechanical thrombectomy.
Yeah, the ICAD there is definitely making the risk much higher, and your I missed the posterior circulation run. The PCOM is again, not really.
Yeah, it's very small.
Yeah, helping. So I guess your options are really to recanalize that chronic occlusion versus. I mean, that seems to be, unless you think by chance that this is a, like you were saying earlier, that this is a embolus on the left side to the A1 A2 junction, which is quite rare. So what's
this was also the thought process, whether to recanalize from the right side ICA and go up, which is also possible, which is not extremely difficult task. Even through vasovasorum, we can enter to the lumen, from the false lumen to true lumen. Only concern was this, although you open this carotid artery, there may be disease at the petrous or the ophthalmic segment, which may not help at all. Then you have to stent from there to, which is little more riskier than. So what I thought, I just support the nature through the anterior communicating complex and go for this thrombus. So I just put a catheter, smaller version of 27 catheter, a 17 catheter across the anterior communicating complex. So you can see now all the three division of right is specifying, and just first thrombectomy passes is fully bright. So all those artifactual thrombus or embolic was nothing. It's just because it was hampered through the left ACA, A1, A2, ACOM complex. That's why it was so poorly specified. So just to compare pre and post, first I thought that there may be a distal embolus where nothing was there. Just one pass through the anterior communicating complex and everything is TK3.
Did you just do IA-TPA and that's it? Or you actually did a mechanical thrombectomy?
Thrombectomy, just one solitary pass.
Interesting. From A1 to A2? Or
yeah. So from this, so from here, I just deployed before lenticular, distal lenticular form and came till here.
You did a ACOM thrombectomy?
Yeah.
You need to write it up.
What was the size of the stent which you used?
I used the smaller 420 solitary.
Okay. Fabulous. Fantastic.
Yeah, great result. Yeah, I don't think I've seen an ACOM thrombectomy published or otherwise. That's really great. Great case. But see, Dr. Ichaporia, it would be very hard to figure this out on CTA, that there is actually possibly a thrombus.
Yeah, maybe. I'm not saying CTA is this thing, but what I'm saying is, why do such a major procedure where you can do it so much easier with IV therapy? I just cannot understand this. I mean, it looks very good. It looks very good, but it's cost a bomb, and we could have got away with a much simpler and easier procedure.
So IV-TPA was not given, Nishant?
No, not given, sir.
But
because
I
of the 2 days history passed.
Yeah, I don't know, Dr. Ichaporia, what do you think the rate of recanalization with IV-TPA is for that? I mean, that seems like a decent sized thrombus.
Yes.
Yeah.
So, the M1 kind of rates, like 30% rate.
30-40%.
Yeah.
But why not give it a shot? It's so much cheaper.
Yeah. Sure.
So that is my view.
But would you wait after you give the IV-TPA? Would
not
you
wait for too long, you see. Not wait for too long, but sometimes you're surprised how quickly it works. And by the time the cath lab is ready and the patient is okay. So I would give it a shot. I must mention, those trials which you showed, those 3 trials with direct, they show non-inferiority. Yeah, fine, perfect. But if we say that there's 30% opening up with IVT, then would it not be more cost effective and more accessible? And therefore you say that if he comes directly to a thrombectomy center, then you would go for direct MT. But if he comes to a peripheral center, then you would drip and ship.
Correct.
So, most of us now, Nishant is lucky to be in a major center, but most of us, we are not so lucky, and we have difficulty with money, with so many things. So therefore, this is my view.
Yeah,
and we got away with it. It's not that we've been unsuccessful. So I think we need to be a little careful, with advocating direct MT at 2 hours. At 2 hours, the guidelines are very clear that you should give IVT.
Yeah, I think the goal of all our efforts is to arrive at a protocol that benefits the maximum number of patients.
Exactly.
And because as much as we want to individualize, none of us have the crystal ball for a given patient. So if more randomized trials do end up showing that direct MT is possibly superior in a thrombectomy center, then I think it'll be clear. But you're absolutely right. Right now, we don't know what's the best protocol.
That's okay in an academic setting. You also have to look at the 3 A's which I mentioned. Affordability being the most important one for our setting. I don't know. I'm sure it's there in America also in a lesser way, but it is a magnified problem in India.
Right. It's just that if direct MT were to be superior in a future randomized trial, you actually could end up saving money because you give the IVTPA, you don't recanalize, and now you're also doing the thrombectomy cost. So that's where I think.
But the difference is not is there. But if you take 1,000 patients and 30% open up, then overall it becomes more cost effective. If 30% open up out of 1,000 or 100, then net it would be definitely more cost effective. Okay, in a few you'd have to go for MT, and we are free with MT. I mean, I advocate it very, very much. But in this case, at 2 hours to go straight in, I have my different opinion.
But we now this patient has undergone an MR, and we have a flare positive small infarct of whatever size. So is it justified to do a mechanical thrombectomy when we are seeing a flare positive infarct which was only 2 days old, and there is a good chance that he may bleed in that infarct if we thrombolize with IVTPA, and we have a ACOM occlusion, the anatomy looks pretty okay, and there are 2 ACAs and 1 MCA is at risk, so it's behaving like a majorosal occlusion, like a T occlusion with a dominant carotid. So why not do a mechanical thrombectomy, which is simpler?
M1 is not occluded, no, in the DSA.
No, but he's at risk. The flow is so slow in the MCA also.
And
you can see the
ICA
flow in the MCA is very slow. I mean, over a period of time,
Yeah, but
she
it's
will
not
develop
occluded.
a big MCA infarct. It's not. No, what I'm
It's
saying
not
is behaving
occluded.
like a. It's not occluded. What I'm saying is behaving like a MCA and bilateral ACA disease, and you are seeing a thrombus sitting at A1.
So this
It's not
would be similar.
bilateral ACA, it's unilateral ACA. The infarct is
No,
on
you can
one
see.
side.
You can see there is a bare area in the left ACA also.
Yeah.
Yeah, maybe, but you see, you're not going to reach there with your MT.
He has.
No.
To A2 you've reached?
So basically, sir, this was a flow restriction. Because of this thrombus, everything was looking that there is distal emboli and everything. It just this plug.
So I don't know. I don't think you have a very strong case. You've done a wonderful job, I must say. But looking at the case per se, evidence-based, you don't have a strong case.
So
what do you think, Sagar? And Dilip?
So in fact, I feel what he has done is correct because he has an evidence that there is a flare positive infarct.
He's
So
done a
obviously
wonderful job.
I mean, as neurointerventionist. I want an excuse to do a mechanical thrombectomy.
Yeah, that is
And
the
I have
problem.
I have an infarct which is flare positive. So why will I take a risk of lysing the patient?
But really, Sagar, I think you're shortchanging yourself by saying that you need an excuse. It's not really that. The same logic or the same evidence that you used, Dr. Chaporia, with the three-phase CTA, where you show in the top panel patient that the collaterals are low. This is that patient. This is that patient who has flow restriction and very low collaterals to the entire right hemisphere. So what's happened is we have gone from the 1950s, where we had all this information, to non-invasive imaging that's not a video, and it's a static image, and we don't get this information in a CTA, and we use three-phase CTA as a poor man's video. But it's the same logic of not having enough flow in that area that makes us do this thrombectomy, not an excuse to do a thrombectomy, really, because any complication is on our hands. So I would agree that this is a correct indication. It's not been studied, and that's the thing with medicine, is that we don't end up studying every possibility. But I think I agree with the statement that this occlusion is actually like a top of the ICA occlusion on the right side, because the right ICA is occluded. Now, if the right ICA was open, then I would totally agree with you, Nasli, that this is just a occlusion of the ACOM, which itself can be bad, but we just don't have enough experience with that. But because the ICA is occluded, this is the correct indication.
And another thing, what I want to say, see, giving IV TPA with a recanalization rate of 30 to 40%, with the devices which we have now, with this kind of anatomy, the vessel opening is close to 99%. I am sure that Nishant,
99.
And, I mean, close to 99. I mean, this
for
vessel,
ACA. Come on.
I mean, it is definitely better than IV TPA for sure. It is definitely better than IV TPA, 100%, any given time.
Yes, sir. Now we are touching those numbers, sir. Seriously. Yeah.
Yeah.
Yes, sir. 90 plus easily, sir. In a reasonable experience, and we are touching more than 90%.
Now what is the definition of reasonably?
No, you should definitely publish that, don't you think, Nasli? You would say
yes,
publish that, right?
You publish that if you're at 99. I think you should publish it. Yes.
If not 99, we are easily some in 90s range, and good realization. Clinical recovery is the second.
At A1, you said at A1 or ACOM or MCA. Where is it 90?
Together.
A1
means MCA, M1, bachelor together.
Okay, I would say around 80 in good hands.
Still, it's twice as compared to IV TPA.
No, I wish we are not comparing.
Yeah, again, I wish that I could say that we are at 80, and every case that doesn't open up reminds me that we are not at 80, because it takes only 1 out of 10 cases to make it 90, and 2 out of 10 to make it 80, and it's hard to keep track with our optimistic minds of the failures. Also, the one thing that's very tricky is the age of the patient. Older patients don't have as good a response, as we all know. And so I think it's, at least our population, the average age is, in the mid to late 70s. And I would say that we are just maybe reaching a 75 to 80% TICI to be a plus rate, at least in Miami. But yeah, definitely nowhere close to 99.
That I would agree with. Sagar, you're being too optimistic.
What I feel is that why are we comparing a treatment which is available at a tertiary care center to a center which is at a periphery where there is no availability of cath lab?
No, we are not comparing. We are not comparing.
So, I mean, this is a fantastic result. I mean, this is fabulous.
I told you it's a fantastic result, but I don't know whether I do it this way. That is this thing. That's my personal view.
Sure.
Yeah,
So
okay.
to summarize, this was the thought process. It was like a T occlusion, is a major vessel occlusion for both hemisphere at the wrist, both ACA and the right MCA. So this is what it is. Day 3 CT scan showing just temporal evolution of left frontal lobe ischemia, nothing more there. And virtually there is no ischemia or progression of infarct on the left side. And by day 4, NHS dropped virtually to 0. And discharge on day 5 or day 6. If we have time, can I finish with this? This is the late window, if time permits. Otherwise, I can stop here.
No, let's do this.
I think do it rapidly because we're getting
Sir,
late now.
done. So 56 a gentleman, dominant hemisphere, very high NHS score. 2 hours, 2 other centers, IVTPA was given. And this was the TOF, all signs of holocranial ischemia. And 2 hours IVTP is given, and by 11, it became worse. Motor aphasic, no improvement in power, and shifted to our center at 2 p.m., virtually after 7 hours. When I examined power 1/5, motor aphasic, and NHS very high, 20, 21. And this is MRI done at our center, which has shown the temporal evolution plus little more ischemia in the external capsular region and flare negative. You can compare morning to afternoon. This is additional one, and this is the temporally evolved.
And flare was negative in both?
Yes, sir. Both negative. This is the last
negative.
one when he came to our center, sir.
Okay, so this is a juicy one, huh?
Sir. So should we go ahead or conserve?
Can we see the angio? Can we see the angiogram? MR angio?
Yes. Yeah.
Yeah.
So cervical IC occlusion and no MCA. Roughly a tandem.
Yeah. It's pretty bad.
Should we go ahead?
Yeah.
So this was angiogram. Again, because it's a borderline, I will do an angiogram to see the collateral score. Very good collateral score for a 57-year gentleman. And tandem lesion, as expected.
So just to clarify, you went with a clinical diffusion mismatch, correct?
Yeah, correct.
Yeah. Yeah, I would do the same.
So just technical to Dr. Sagar Oak and Dr. Yavagal, thrombectomy first or stenting first and then thrombectomy?
My bias is now towards stenting first. I find that the flow, even intracranially, is much better when I stent first, and my first pass rate of success is better when I have a good solid flow from the carotid. And so I've really, over the last 2-3 years, shifted to stenting first. Also, when we're doing thrombectomy and such, if the carotid closes down as we are pulling the thrombus back, it can be a problem. Your device can get stuck in the carotid. So I have really moved towards stenting first.
Dr. Sagar.
So, I mean, this is a new learning for me, because what we are doing, sir, is that I'm using a balloon guide 9F and do a balloon angioplasty first and then use Solumbra or suction. So I have an access across the carotid, and then after doing thrombectomy, we put a stent while coming back. That's what we are doing so far. But this is, I mean, I don't know how safe it is to take the guiding through the stent. That's my only question.
Yeah,
so
it's
whether
not
it
a
is
problem.
safe or
okay. Yeah, it's very safe actually. Yeah, so it's never actually caused a problem. Now, if you have a very angulated, highly angulated origin, or there is heavy calcification, that can possibly give you a problem, but I actually haven't come across that. And now we've done stenting first, and I would say more than 20 or 25 cases with pretty good results.
Okay.
Thanks.
So, and do you use a covered stent or you use a regular
No,
wall
regular
stent?
stent. Yeah, regular, Guidant or a Protege exact stent.
So this I use a different technique of balloon override. It's called in literature rocket technique. I'm just writing it up in terms of partially inflate the balloon, and over that you can take your balloon guide up. So this is what I did. You can see my balloon partially inflated, and I use it as a guide wire and go across. So this is the first inflation of the balloon. And now you can see over that balloon on my catheter is the cervical ICA. Large chunk of clot is removed. And just by aspiration of the cervical ICA, everything got open. TK3.
Nice.
So what it did was, it was making a very close space because the mild vasospasm it creates through in the cervical ICA. So it created full closed space to bring the thrombus out in one go. So just to compare, this is the pre-thrombectomy. After post-thrombectomy and plasty, this is what I got. So again, just a very brief answer from the panelists: stent or not to stent, given in this case the size of ischemia.
Yeah, I would again stent for the reocclusion reason, and I know there is a pretty big stroke, but just like you had in the other case, without aspirin Plavix, this is highly likely to shut down. And if you're going to give aspirin and Plavix, I would put a stent.
Even I would put a stent in this patient because the vessel, the current hasn't opened very well in this patient, I feel.
Yeah.
There is
a bad plaque. Same thought process. Yeah. So this is what I did. Here also you can see there is a small thrombus stuck at the mouth of the spider device.
Wow.
Usually I don't do a post plasty, but because it was recoiling to a very significant extent, so I just post plastied it. And this is post plasty, mild vasospasm, nothing to worry about, just little bit pneumodipine I put. And this is the large chunk of thrombus at the mouth of spider device. And this is TK3 in the middle cerebral artery. Because AC was preferentially filling from the right side, it was just a flash filling. And it remained open. This is half an hour post. And here you can see TK3 in here is the preferential filling through the ACOM. That's why it's a flash filling. Otherwise, it's TK3. Day one, he started in speech monosyllables, power from 0 to 1 became 3. And this is day 2 CT scan. Very small area of ischemia in the basal ganglia area and external capsule. Rest of the whole frontal lobe parietal and posterior parietal is preserved. And day 4, he became better. And day 7, virtually an ICU from 20 to 6. For me also, for this kind of basal ganglia ischemia, it was a very good outcome for is rare, virtually rare for me also.
With such a proximal M1 ischemia. Yeah. I have a question to Dr. Yavagal. Do you use a protection device when you put a stent first, or you just put a stent, do a balloon angioplasty and put a stent, or you use a protection device and then put a stent?
Yeah, I oftentimes, for the sake of speed, especially when we have a distal M1 occlusion, I will not put a protection device, because if something goes up, anyway the M1 is occluded and we have to take it out. But again, it's it's something that you can see in these two cases. If your M1 is open and it's just an M2 occlusion or something, and your carotid is occluded, I think it does make sense to use a distal protection. You just have to get very fast with your stenting, which normally, we do it very systematically and take our time. This is a very rapid stenting you have to do along with a protection device. So I would say in about 60 to 70% of my cases, I don't use a protection device.
Okay. So what I'm using a C-guard which is covered by a mesh from the outside, so it gives like a post stenting embolic protection. and I am using balloon inflation when I'm putting a stent, and I don't really use in acute setting a protection device, which probably I need to look at. But in acute setting, we just do a thrombectomy and put a stent with balloon inflation to avoid. So far, we haven't experienced any distal embolization, but he has retrieved thrombus into the spider. So this is something to.
Yeah, if you're doing it after you've done the M1 thrombectomy, you're better off because now you have time. You have opened the M1, your brain is perfusing. Then I would really minimize the risk of distal embolization, which, as you can see from these cases, can happen. So you have all the time in the world to, properly put the distal protection device in place and then put a stent. I do it on the way up, and that's when there is a need for a lot of speed. So I've been skipping the distal protection for those reasons.
So I'm done. Thank you so much.
Great cases. Congratulations.
Beautiful cases. Amazing cases.
Thank you, sir. Thank you.
Thank you very much.
Thank you.
Thank you, Dr. Avagal. Thank you, Nashli. Thank you, Sagar. And of course, Dr. Nishant Aditya. So I think that brings the end of the conversations, and I think we'll thank you, everybody. Yeah.
Thank you so much. Bye-bye.
I'll just quickly say a vote of thanks. On behalf of the organizing committee, I extend a very hearty vote of thanks to all our faculty, all our chairperson speakers for this splendid academic webinar. Thanks to our CEO, Dr. Tarang Gyanchandani, who graced the occasion last evening. Special thanks also to Additional Medical Director, Dr. Gami Vaswani, who has supported us at every instance, at every meeting. I must mention our deep sense of appreciation for our marketing team also, who's been there all around. Mr. Aditya Bahadur, Mr. Sanjay Verma, Ms. Karishma Haldankar, and team for all the assistance. Dr. Rishiraj Panwar from the medical admin for doing the formalities to acquire the MMC points for the webinar. Thanks to Mr. Gurpreet and the FMB team for all the hospitality. Thanks to our IT team and their relentless efforts. Finally, I would like to take this opportunity to place on record our hearty thanks to Mr. Yogesh from Sun Pharma and Mr. Dinesh from Digital Info Media Solution for providing seamless IT integration throughout this webinar. Thank you so much. Thank you. Bye.
Bye-bye.